Hello, hi, good morning. I think now the situation is better. I think, yeah, it must be fine now. Okay, let us start with where we left today. I think there are a few more diseases that are left. So I think we need to discuss on MCTD, a few words on mixed contingency disorder. Then we have a few words to be told about Raynaud's. Then we have a few words to be told on idiopathic inflammatory myositis. Then we have a few words to be told on vasculitis. So these are the four things that we have right now. Sarcoidosis, I think we can do it in pulmonary medicine. I think it's done extensively already there. It's in the app. And plus, anyways, we'll try to do it in pulmonary medicine if possible. So what we're going to do is MCTD, mixed contingency disease first. It's very simple. So as the name suggests, MCTD means, like you're going to have multiple like problems with regards to contingency disorder in the same patient. So that's what is going to happen here. So that is what we define as something called MCTD in the first place. So what are the features? If somebody asks you what is the most common feature that you get as a result of MCTD, what will be your answer? Suppose if somebody wants to tell what is the most common feature in a mixed contingency disorder, what will be the finding? To start with, we need to tell that Raynaud's is going to be the most common. It's seen in more than 80% of the individuals. Raynaud's is going to be the most common. So out of all, and they can show pictures similar to that of SLE. They can show pictures similar to that of scleroderma. They can show pictures similar to that of myositis. Sometimes even they can show pictures similar to that of even rheumatoid arthritis. So that's why we call it as a mixed TDD. But even though rheumatoid arthritis kind of a setting is actually quite uncommon. So now next, apart from that, they can show scleroderma-like picture. That's quite common. As far as scleroderma-like picture is concerned, usually they will be coming with this kind of edema that's called as puffy hands, and probably they can develop sclerodactyly over a period of time. That's really important. And at the same time, they can develop certain SLE-like manifestations, including serositis, like pericarditis, pleuritis, and that can result in the development of chest pain. And at the same time, they can also develop pulmonary involvement, resulting in the development of either ILD or even it could be a pulmonary artery hypertension. Plus, they can develop myositis, mimicking polymyositis or dermatomyositis. Plus, at the same time, they can like rheumatoid arthritis like arthritis, and it could be erosive as well. Could be, I'm not telling always, it could be erosive as well. So if you see this picture, like it's like a combination of multiple like disorders, systemic sclerosis, SLE, then you have myositis, then Raynaud's, then you have rheumatoid arthritis. So multiple picture in the same patient. So usually, I mean, whatever may be the picture, at one point of time, they should predominate some form of disease. Usually, either they go like a systemic sclerosis like picture over a period of time, or they will go to a SLA-like picture. Mostly the dominant picture over time, maybe around 5 years mark, around after 3 to 5 years, usually they go either towards a systemic sclerosis-like picture or they will become an SLA-like picture. But to start with, these are the pictures. This is how they start with usually. But most common, if they ask you an MCTD, that is Raynaud's, seen in more than 80% of the individuals. At the same time, diagnosis is quite simple. As far as the investigations is concerned, you know that ANA is going to be very important, and most of the case will be ANA positive, and most important antibody is going to be anti-U1-RNP positivity. So when you have this kind of clinical picture with ANA positivity and anti-U1-RNP positivity, definitely, you're going to think about a MCTD-like picture. Or they can have a rheumatoid factor positivity as well. That's also seen in many patients, like almost like 30 to 70% of the patients may have rheumatoid factor positivity. And as far as ANN and U1-RNP is concerned, approximately around 90 to 100% of the patients, all the patients will have ANA positivity and anti-U1-RNP positivity. So U1-RNP is considered to be extremely sensitive, which means almost all patients with MCTD will have some form of, ANA that is anti-U1-RNP positivity. In this patients with mixed contingency disorder, And depending on which is the dominant disease, for example, if you have SSC-like disease, or if you have SLE-like disease, or if you have rheumatoid arthritis like arthritis, which is predominating. So depending on that, the treatment will be dependent on that. So there is no particular treatment for MCDD. So since we have discussed all the other disorders, you're going to just treat like which disorders are going to be most dominant in this setting. So this is mixed CTD, not a very common entity, but a very rare entity. Then we have something called a Raynaud's. So Raynaud's can happen because of primary issue, that is in the functioning of the vessel wall, or it can be in the damage to the vessel caused by certain disorders like SLE, scleroderma. All these things can have Raynaud's phenomenon as well. But nevertheless, you know the characteristic three features of Raynaud's. So initially they will become white, then become cyanosed, then they'll become red because of the reperfusion. So first, initially there will be an ischemic phase, and in ischemic phase they will become white, and it's more pronounced in Caucasians. There will be a blanching. Then there will be a hypoxic phase. During hypoxic phase they will become blue and cyanosed, and during reperfusion stage later on they'll become red. That is because of the reperfusion. So this is the three characteristic, clinical manifestation of Raynaud's phenomenon. This is how they goes. And most of the time, this will happen only if the exposure happens to cold. So if there is no exposure to cold, so usually this does not happen. So don't diagnose unless and until the patient has no significant exposure to cold. Sometimes it can happen with stress also, but nevertheless, the cold exposure is going to be the most important. If there is no cold exposure, and if you think about Raynaud's phenomenon, you are most likely to be wrong. So don't diagnose Raynaud's phenomenon unless until you have a significant amount of cold exposure. And most of these changes will be well visible. So it's not like very difficult to miss this Raynaud's. It's very simple and more pronounced in Caucasians and Indians. It is not that easy to see in the first place. So now we need to know the difference between a primary and a secondary Raynaud. Primary Raynaud, we know it's idiopathic. We don't have any underlying cause. Secondary, we clearly have an underlying cause. As far as primary Raynaud's is concerned, the vessels are functionally abnormal, whereas in secondary Raynaud's phenomenon, the vessels are structurally abnormal, which means there is some basic damage to the vessel that is going on. And the best example of secondary Raynaud's is probably you can talk about a systemic sclerosis from yesterday we've been talking about. Then even SLE can produce a secondary Raynaud-like picture. A lot of vasculitis, especially the medium vessel vasculitis and the small vessel vasculitis, can produce secondary Raynaud's. And CPDs like APLA syndrome, antiphospholipid antibody syndrome, can result in development of secondary Raynaud's, and very rarely some drugs are there which can produce secondary Raynaud's, especially like your ergot compounds, cocaine, because they are powerful vasoconstrictors. In that setting, you can get Raynaud's phenomenon as well. But as far as exam is concerned, the vasculitis and the rheumatological causes remain really, really important. I mean, there are many findings are there, but among all, the vasculitis and the rheumatologic causes in exams becomes most important as far as secondary Raynaud's is concerned. So as far as the age group is concerned, usually it will be of younger age group, 20 to 40 years, young to middle age group, and typically very common in females compared to that of the males. As far as the secondary Raynaud's is concerned, usually it will be in older age group, more than 40 years, and once again, females will be more commonly affected than males. So this is for secondary Raynaud's phenomenon. As far as the clinical features are concerned, attacks will be more symmetric in nature, whereas secondary Raynaud's tend to be more asymmetric in nature. Usually there will be no element of tissue injury, no injury as such because of this kind of Raynaud's. So they won't go for that necrosis. They won't go for that kind of infarcts in the short period of time that during the time that they get the Raynaud's. But as far as the secondary Raynaud's is concerned, usually they'll be associated with severe ischemia and injury. They can go for digital infarcts. Yesterday we saw in scleroderma, in a digital ulceration, digital infarcts. So that's quite common. Similarly, the most important point that you need to know for the exams is the fact that primary Raynaud's will spare the thumb. So thumb will usually not involved in the primary Raynaud's, whereas in secondary Raynaud's, they don't spare the thumb. They affect the thumbs also. Do not spare thumb, which means all the fingers can be involved. So thumb will not be spared in this setting. So as far as the nail fold capillaroscopy is concerned, there will be a normal nail fold capillaroscopy. Yesterday we saw in scleroderma there was a significant dropout of nail fold capillaries in the nail fold capillaroscopy. So if you do a nail fold capillaroscopy, there will be normal capillaries. There won't be any significant dropout or tortuous vessels. So in the setting of a secondary Raynaud, you will see this distorted tortuous capillaries. Along with that, there might be a significant dropout in the number of capillaries. So this could be the finding. So if somebody asks you what is the difference between primary and secondary Raynauds, this is what you're going to answer. Primary, idiopathic, and most importantly, it's past the thumb. There's no significant injury or hypoxia, ischemia that is happening to the area that is going for Raynauds. And mostly it will be more symmetric, predominantly in a little younger age group, and it's a functionally abnormal vessel. Technically, it's not a structurally abnormal vessel. And more importantly, they might have a normal capillaries in nail fold capillaroscopy, whereas secondary Raynauds will tend to have a abnormal nail fold capillaroscopy. The most important treatment of any form of Raynauds is to avoid the cold. That's very important. Apart from that, anything that produces vasoconstriction should be avoided. For example, drugs that are sympathomimetic drugs like cocaine and any other sympathomimetic drug. Even cigarette can cause vasoconstriction. So cigarette should be avoided. So conservative treatment is very important. Then at the same time, you have to avoid exposure to the cold, in the sense you have to wear gloves, protective gloves. Protective wearing is very, very important. Suppose if your initial conservative management is not working, then you can go for the drug management. The most important drugs in this setting are the vasodilators that we are going to use. You can prefer using calcium channel blockers. You can prefer using nitrates. You can prefer using certain angiotensin receptor blockers like telmisartan, which are supposed to be a little effective. Then you can use alpha blockers as well. To prevent from going for thrombosis, you can use aspirin, clopidogrel, and other antiplatelet agents to avoid development of thrombosis. If these are not responding and if it is severe enough to cause a severe attack, then you can go for phosphodiesterase 5 inhibitors. There is one surgery that is advocated for Raynaud's syndrome. What is the surgery that you think it will be advocated? Phosphodiesterase 5 inhibitors like sildenafil, tadalafil can be done. Then if still it is not responding, then you can go for certain surgeries. What is that surgery? Yeah, sympathectomy. So there are many forms of sympathectomy are available. You can do it in the spinal cord, or you can do it in the digits also, called as digital sympathectomy. You're going to go for sympathectomy. Plus or minus, you can try even before that IV prostaglandins, but I don't think that's really needed. But usually they will respond very well to conservative management itself, like just wearing protective gloves, avoiding exposure to cold, and avoiding the triggers for Raynaud's like sympathomimetic drugs, stopping the smoking, and this must be itself more than enough as far as the Raynaud's phenomenon is concerned. So usually in exam, the area that will be considered will be the difference between the primary and the secondary Raynaud. These sort of things can be asked as a sort of a picture. So some pictorial memory is also important in this setting. And apart from that, MCTD, usually they will be concentrating only on that anti-U1 RNP antibody. Apart from that, in MCTD, you won't get any much questions. So once we have finished this, now I think we have another topic called as IAM, that is idiopathic inflammatory myositis, and you have multiple differential diagnoses as far as the idiopathic inflammatory myositis is concerned. So that also is something very important to know. So as far as the idiopathic inflammatory myositis is concerned, we have a classification system called as Bohan and Peter classification system. So this was given in 1962. So as far as the Bohan and Peter classification system is concerned, they are classified into 4 to 5 different categories. One is called adult polymyositis, number 1. And second one, they called it as something called adult dermatomyositis, number 2. Then third category is called as juvenile dermatomyositis, number 3. Number 4, they called it as the malignancy associated myositis, which means it could be dermatomyositis or it could be polymyositis. So they called it as a malignancy associated myositis as a separate entity. And the 5th category they gave is the connective tissue disorder associated myositis, CTD associated myositis. Usually this will be a dermatomyositis, CTD associated myositis. But nevertheless, there was one more thing that was not actually included in the original Bohan and Peter classification, which was included later. that is sporadic inclusion body myositis, SIBM. SIBM stands for sporadic inclusion body myositis. So this is the one that was not there in the original Bowen and Peter classification. But after that, it was subsequently included because we started seeing a lot of cases of sporadic inclusion body myositis also. So adult polymyositis, adult dermatomyositis, juvenile dermatomyositis, malignancy-associated myositis, CTD-associated myositis, and finally we have a sporadic inclusion body myositis. So, but overall, we can put these things under two headings. One is dermatomyositis, second is polymyositis. That's all. And third is probably sporadic inclusion body myositis. Even though Bowen and Peter classification tells these sort of different things, for a basic understanding for exams, it's better to put only two headings and compare them. What is going to happen there? Polymyositis and dermatomyositis can be put under similar category, and sporadic inclusion body myositis can be put under a separate category. So let us see the comparison so that you will be understanding much better and it will be easier for exams as well. So when you take the gender distribution, sex distribution, polymyositis, dermatomyositis is going to be common in females compared to that of the males. Whereas sporadic inclusion body myositis is supposed to be almost equal in sex preponderance. Like they don't have any particular sex preponderance. Usually they can have both male and female sex ratio as equal, females equal to males. As far as age is concerned, usually polymyositis and dermatomyositis will happen in age less than 50, whereas sporadic inclusion body myositis is going to happen in older age patients. It's very, very important. Elderly only. Usually age more than 50, they'll be 55, 65. So very elderly patients most of the times. And as far as the muscle involvement is concerned, it will be symmetric in the setting of a polymyositis and dermatomyositis, whereas it will be asymmetric in sporadic inclusion body myositis. This is a very important point. This is the one thing that differentiates sporadic inclusion body myositis in exams as well. It will be different. It will be asymmetric. And muscle involvement mostly will be involving proximal muscles. Very late stages, they can go for distal muscles, but usually it will start and it will be continuing with the proximal musculature only. Whereas sporadic inclusion body myositis may have both proximal and distal muscles. As far as the muscle involvement is concerned in sporadic inclusion body myositis, two muscles are extremely sensitive, one proximal muscle and one distal muscle. The proximal muscle that is very commonly affected in sporadic inclusion body myositis is quadriceps. This quadriceps involvement is very important because in exam, they will give history of recurrent falls. So whenever there is an elderly fall, you have a multiple differential diagnosis, right from your neurocognitive disorders, like your dementia to your progressive supranuclear palsy also can present with falls. Even sporadic inclusion body myositis can present with falls. Even drug-induced hyponatremias, SAADH can also present with falls. So elderly falls itself is one of the geriatric giant, and that needs a completely patterned approach that we're not going to discuss anyways. So quadriceps affection will result in development of falls and subsequent fractures that could be the presentation of sporadic inclusion body myositis. And apart from that, second muscle that can happen is long finger flexors. So they can, grip weakness will be there. They cannot grip properly. That is because of the long finger flexors will be affected. That's number two. So this is the muscle involvement that you're going to get. As far as the neuropathy is concerned, neuropathy is not usually a feature of polymyositis and dermatomyositis, but commonly seen in the setting of a sporadic inclusion body myositis. As far as the internal organ involvement, for example, cardiac involvement, pulmonary involvement is concerned, internal organ involvement is quite common with polymyositis and dermatomyositis, whereas it is completely uncommon with sporadic inclusion body myositis. When you take skin involvement can happen with polymyositis and dermatomyositis, where it is uncommon with sporadic inclusion body myositis. But remember, skin involvement is extremely common with dermatomyositis compared to that of polymyositis. We know that, even though there are evidences that polymyositis also have some element of skin involvement, but dermatomyositis is the one that classically produces skin involvement. We'll be seeing what are the skin involvement in some time. Apart from that, if you take the antibodies, whether they are present or not, antibodies are very characteristic of polymyositis and dermatomyositis. When you go for exams, you have to tell antibodies are absent in sporadic inclusion body myositis, but you can put a star here, conditions apply, which means there are some new antibodies that have been described. Some 2 to 3 antibodies are already been described in 2017 and 18. So which is still, like not coming in many textbooks, but still that's important to know. As far as exams are concerned, antibodies are not very important in sporadic inclusion body myositis, and you have to tell that only. But in special conditions, I'll tell later on, there are 2 antibodies which can be seen in sporadic inclusion body myositis as well. When you do EMG, electromyography, typically they will be showing only myopathic potentials because they are pure myositis and myopathy related problems. Whereas in sporadic inclusion body myositis, they will be having myopathic and neuropathic potentials because of their ability to cause neuropathy as well. As far as creatine phosphokinase is concerned, there will be significant elevation. At least there will be more than 10 times elevation from the upper limit of normal value. Here in sporadic inclusion body myositis, usually the CPK levels will be normal, or there will be only mild elevation, which means there will be elevation less than 5 to 10 times the upper limit of normal. It won't be like huge elevation. Most of the time it will be normal. Next, we need to ask whether is there any association with MCTD? Yes. As I told you in the beginning itself, one of the important component of MCTD could be myositis. There is association with myositis. Here there is no association with myositis. MCTD usually. Or you can write other CTDs also. Is there any association with other CTDs? Polymyositis, dermatomyositis, yes, but sporadic inclusion body myositis do not become a part of any other connective tissue disorder. Then is there any association malignancy? Which means can this myositis could be a part of paraneoplastic syndrome? Yes, here, absolutely no. Sporadic inclusion body myositis is not a part of any paraneoplastic syndrome. Can it happen in children? Can it happen in children? Yes, for polymyositis and dermatomyositis, but no for sporadic inclusion body myositis. But if they ask you about children, the only one thing that usually commonly present in children is dermatomyositis. That's why Bowen and Peter classification had something called a juvenile dermatomyositis separately as a separate entity. Then gold standard, of course, is going to be the muscle biopsy only. We need to do a biopsy, and that's going to be the gold standard for diagnosis. So what will be the finding that you'll be seeing in polymyositis and dermatomyositis is something different. So, of course, you will be seeing a lot of inflammation. Inflammation will be there. And where is the inflammation will characterize whether it's a dermatomyositis or polymyositis, which I'll tell you in some time. Apart from that, necrosis will be less. There'll be not much of necrosis, but there'll be muscle fascicular atrophy. And a lot of fascicles will go for atrophy. There will be smaller fascicles that will be seeing, the fibers will be there. And at the same time, there will be no inclusion bodies. This is very characteristic of a dermatomyositis and a polymyositis. But remember, what is the type of inflammation will tell you whether it is a polymyositis or a dermatomyositis, which I'll tell you subsequently. As far as sporadic inclusion body myositis is concerned, the inflammation will be very less here. You won't get that much of inflammation. There won't be any necrosis. Necrosis will not be there at all. Still, there can be atrophy of fascicles. And typically, you will see the inclusion bodies. That's very characteristic. So what is the inclusion body that you see here? These are intracellular inclusion bodies, basically. They are called as vacuolated intracellular beta amyloid inclusion bodies. Usually amyloid means it's extracellular only. This is one exception where you can have an intracellular amyloid. And this vacuoles will be a kind of a rimming appearance will be there. That's why it's called a beta amyloid with rimmed vacuoles. So whenever you encounter a vacuolated inclusion bodies or a beta amyloid inclusion bodies or with the rimmed vacuoles, this kind of statement, I'll show you the image in some time. If you get this kind of statement, that is usually going towards a inclusion body myositis. That's why the name came. That's a sporadic inclusion body myositis in the first place. Then if you take the steroids response, whether steroids show good response or not, yes, immunosuppression show a decent response in the setting of polymyositis, dermatomyositis, but whereas in sporadic inclusion body myositis, your immunosuppression is not going to show a good response at all. That's why sporadic inclusion body myositis is like a variant. You can put dermatomyositis and polymyositis together, but sporadic inclusion body myositis is completely different. Then coming to the characteristic features of the polymyositis and dermatomyositis. What are the characteristic features? Only few things we're going to see. The most important is going to be the skin features and the muscle features. That's what we're going to see. Of course, the first feature is going to be symmetric muscle weakness. Symmetric muscle weakness that will be proximal in nature. Proximal in nature. And remember, they will be affecting only the skeletal muscles. They will not be affecting the smooth muscles usually. I mean, they can have cardiac involvement. That is different. That's a different part of the disease. But as far as the myositis is concerned, they will have only skeletal muscle involvement. They typically affect only the skeletal muscles, which means we are talking about only the striated muscles. They will not affect the non-striated muscles, especially the smooth muscles. Clear? And more importantly, whether they'll be associated with pain or they'll be not associated with pain. That's the question. So pain is a feature or pain is not a feature. In the setting of, inflammatory myositis, we're talking about idiopathic inflammatory myositis. Will there be a muscle pain and tenderness, or there won't be muscle pain and tenderness? In the setting of myositis, I'm asking you. Yeah, everyone is telling pain is there, but pain is not a very important feature. Actually, these disorders will be painless. They will not have significant pain and tenderness. Suppose if there is a significant pain, in this setting, you need to think about alternative possibilities. For example, you can think about a thyroid myopathy, hypo or hyperthyroidism. Then probably you can think about a drug-induced myositis. It could be a drug-induced cause. It could be a drug-induced myositis. Or probably you can think about an infectious myositis. Drug-induced means we're talking about statins there. Infectious myositis. Or probably you can think about very deadly possibilities like NAM. That's called a necrotizing autoimmune myositis. NAM, necrotizing autoimmune myositis. So these are some of the other possibilities if suppose the patient is having a significant pain. Otherwise, the patient should not really have significant amount of pain. Usually these disorders will be having no or only mild pain. Yeah, inflammation is there, but they're not characterized by muscle pain at all. So that is very characteristic. That's why I told you that point specifically. And they are not going to produce significant pain. That's a very characteristic feature. And even though the striated muscles are affected, the skeletal muscles are affected, usually they do not involve the extraocular muscles and they do not involve the facial muscles, which means extremely rare. That point is again important because that differentiate you to some extent from other myopathies. So the idiopathic inflammatory myositis rarely involve the extraocular muscles and the facial muscles. So usually they are spared. But there are some exceptional cases where you can have involvement of these muscles also. But in exams, you can tell that these muscles are generally not involved. Of course, yes. Clear? So whenever you do an EMG, as I told you, you'll get a characteristic myopathic potential and the enzymes of muscle, necrosis or not muscle necrosis, muscle damage. That's what you can tell because here there will be significant necrosis. Here there will be more of inflammation than necrosis. So whenever you do enzymes assay that is involved in diagnosing the injury to the muscles, they will be elevated. For example, what are the enzymes that can be elevated? CPK will be elevated. It's not only about the CPK, even LDH can be elevated because it also has a muscle isoform is there. Then aldolase B, there is another enzyme. So even this can be elevated to some extent. Even AST is there. That also has a muscle isoform. So even AST can be elevated. So, but in the sense, if I'm going to do a nerve conduction study, because this is not a neurological problem, so if I'm going to conduct a NCS, it will be absolutely normal. There won't be any problem in any detectable change in the nerve conduction study. Apart from that, there are other findings that can be associated with polymyositis is the esophageal dysmotility. Because of muscle involvement, esophageal dysmotility can be associated. There's a completely different entity which can result in the development of dysphagia, which can be seen in approximately 30% of the polymyositis and dermatomyositis cases. That is not due to the muscle involvement. Rather, these disorders, you can remember, like they can have a sort of overlap, like scleroderma, where esophageal dysmotility is extremely common, and these patients, 30% of them can have a dysphagia. And even this dysphagia can be very severe, that can result in nasal regurgitation also. So that's where this is important. So these are the muscle involvement, problem number 1, which we have discussed. What are the characteristic features of the muscle weakness? In that, most important feature will be the painless nature, which means pain may be there, but very little. It's not very significant. Pain will not be the most important feature. The weakness will be the most important feature, the proximal weakness. Number 2, second one is the dermatological problems. What are the skin manifestations? Of course, you know the skin manifestations are absolutely common in dermatomyositis than polymyositis, even though there are some features that can be seen in polymyositis as well. So what are the skin manifestations? Number 1 is the classic heliotrope rash. We know what is heliotrope rash. Heliotrope is a plant which is blue in color. So you have a purplish blue rash around the eyes. This is what we refer to as something called a heliotrope rash. Then we have a V neck sign. So typically the rash is involving the V area of the neck. That is called a V-neck sign. Then you have the third one, that's called a shawl sign. You would have seen politicians wearing a shawl. Where they're wearing a shawl, you'll get a rash in that area. So if you get a shawl area, if you get the rash, that's called a shawl sign. Then finally, you have something called Holster sign. Holster sign is nothing but getting a rash in the thighs. That's called Holster sign. And apart from that, you have the characteristic Gottran rash and Gottran papules. So Gottran rash is very characteristic of dermatomyositis with a high degree of specificity. Typically, the rash will be present in the joint area, that is in the MCP joint area, and they can be present in the PIP joint area, that is proximal appendigeal joint, and they can be present in between the area between PIP and MCP as well. So that's very characteristic. You will get kind of a rash and a papular kind of an appearance. That's what we call as a Gottran rash. It's very important to differentiate that from something called a systemic lupus erythematosus rash, where systemic lupus erythematosus rash will not involve the joints. They will only involve the skin in between the joints. For example, if you see these rashes over here, which I've been discussing, if you see the rashes over here, so this is the characteristic heliotrope rash. We know that, isn't it? So why the name came? Because it's looking like something sort of an heliotrope plant, which is blue in color. So that's why it's called heliotrope rash. Then you have this typical V-neck sign. Then you have the shawl sign, the shawl area. Then you have this kind of rash in the thighs. This is Holster sign. And of course, this is typical of a Gottran rash. You can see in the joint area, or probably you can see in between the joints also. That's not like something going to exclude. So this is very typical of a Gottran rash. You can see the rash here also, typical of a Gottran rash. But as far as the SLE rash is concerned, this is a patient who's suffering from ACLE, that is generalized ACLE. We call it as generalized acute cutaneous lupus erythematosus. So where it spares the joints. Typically, you don't get rash in the joints alone. You get only the rash in between the joints. So this is typical of a generalized ACLE. So you need to really differentiate this Gottran rash from the generalized acute cutaneous lupus erythematosus rash. So that's an important point here to note. So we have the Gottran rash. Apart from that, one more thing we saw the picture, but I didn't really tell you about that. That's called a mechanic's hand. So perhaps this is a very important finding, because this mechanic's hand is one finding that can be seen in both dermatomyositis as well as polymyositis, even though in reality we see in polymyositis more than dermatomyositis, but this is one finding that can be seen in both these conditions, mechanic's hand. I'll tell you why, because this sort of confusions, why they happen, because of the antibodies that we are dealing with. We take this picture, this is the example of a mechanic's hand that we see. You can see this kind of crusting and hyperkeratosis will be there. You can see this crusting and hyperkeratosis on the radial aspect. So this is a radial aspect, and it's very common on the index finger only. It's common on the index finger. So this kind of crusting, hyperkeratosis, skin thickening. So this looks like a hand of a manual laborer. In the textbooks, it's a characteristic description, ugly looking hand like that of a manual laborer. So that's why this is called as a mechanic's hand. So it can be seen in both dermatomyositis as well as polymyositis, but I'll tell you why it is the case, because it's a marker of one particular antibody that we're going to discuss in some time. So these are the skin manifestations that you generally tend to see in the setting of dermatomyositis or polymyositis. As far as nail fold capsularoscopy is concerned, which will be abnormal? Dermatomyositis will show abnormality, or polymyositis will show abnormality? I think we have discussed yesterday. Somebody who have listened to yesterday's class must be able to answer this question. Nail fold capillaroscopy. It's a fine. I mean, it's abnormal. It's abnormal in polymyositis, or it is abnormal in dermatomyositis, where it is abnormal. Yes, we discussed yesterday itself. This is abnormal in dermatomyositis, where you can see the similar finding to that of systemic sclerosis, like capillary dropout, tortuous vessels. Because dermatomyositis is more of a vascular disease. It's going to affect the vessels than the polymyositis. Okay, all right. But when you do a biopsy, I told you, is the gold standard for diagnosis of any kind of myositis, idiopathic inflammatory myositis. But on the other hand, dermatomyositis has some characteristic finding, and polymyositis has some characteristic finding. So first one, let us talk about the polymyositis. As far as polymyositis is concerned, the inflammation will be a kind of a diffuse inflammation, which will be involving all the fascicles uniformly. So there will be uniform inflammation of the entire muscle area that you are looking for. And at the same time, there will be no vascular preference. In the sense, like, it's not like they will be concentrated around a particular vessel. So there will be no vascular preference, and there will be uniform inflammation. And at the same time, there will be a CD8 infiltration rather than a CD4 infiltration. There will be a CD8 infiltration. Apart from that, both of them can show atrophy. Both of them can show that kind of inflammatory cells, and both of them will not show that much of necrosis. So that's not going to differentiate. So I'm telling only the differentiating points now. The type of inflammation will be more uniform. So this kind of uniform inflammation with no vascular preference is what we refer to as something called a perimysial inflammation. Perimysial inflammation. If you want to note that word, you can note. Otherwise, you not note that word. Okay. On the other hand, if you take a dermatomyositis, it will be more of a disuniform inflammation. They will be having a kind of a vascular preference, in the sense around the vessels only they'll be showing a lot of inflammation, which means there will be something called a characteristic perifascicular atrophy. Perifascicular, perimysial atrophy will be there, and there will be a selected vascular preferences there. So that is characteristic of a dermatomyositis, and more often it will be a CD4 infiltration rather than a CD8 infiltration, the setting of a dermatomyositis. So you'll not be understanding unless until you see the image, because once you see the image, it will be a little easier. So this is a very good image of dermatomyositis and polymyositis, where you can see this is a normal musculature in the first place. Let me draw a different color. This is a normal muscle, in the sense like normal muscle fascicle will look something like this. The shape will be something like this, and you can see the peripherally placed nucleus. So why the nucleus peripherally placed? Because they have abundant glycogen. Because of the glycogen stores, the nucleus will be pushed towards the periphery. So this is a normal looking muscle. And like whenever you look this muscle, this is not looking good really. If you look this kind of a muscle, it's not good at all. Why it's not good? Because you are seeing a lot of blues here. So whenever you see these kind of blues in different areas, a blue always indicates inflammation. Blue is never good. Blue is always bad in pathology. So a lot of blues here indicates inflammation. There's a characteristic polymyositis, because I'm not having any preference over here. I'm seeing inflammation in all the areas in between the muscle fascicles, everywhere. But wherever there is significant inflammation, you can see the muscle fibers are going for atrophy there. So there are smaller fibers over here. So this is atrophy basically. So these fibers have already gone for atrophy. But if you compare with this, you can see like how nice and uniform these fibers are. So correct, like equal shape. There's no size discrepancy here. There is a lot of size discrepancy in areas of inflammation. You can see these fibers are basically going for tremendous atrophy over here. So the small fibers indicate atrophy. So inflammation, diffuse, not very, like selected areas, it's not affecting. So that's typically a polymyositis. On the other hand, if you take a dermatomyositis, this is an example of a dermatomyositis, where you can see this is fascicle, muscle fascicle, and you have a lot of muscle fibers inside them. And if you see, this is the vascular area. This is the fascicle, and this is the vessel that is running through around this particular fascicle. And you see more of a perifascicular atrophy and perifascicular inflammation. Like the inflammatory cells are actually concentrated in this area more. And in the deeper areas, you don't really get that much of inflammation. And you are seeing a good number of muscle fiber distribution inside. Inside, you don't have any problem at all. But this perivascular area, this is the place where you're seeing all the inflammatory cells that are concentrated. And at the same time, this is the areas that you are looking for in the setting of a atrophy also. So this is what we typically called as a perifascicular atrophy, and more of a perifascicular inflammation, which is having a vascular preponderance, and all these things goes towards a dermatomyositis. And it's more of a CD4 infiltrate, whereas in polymyositis will be more of a CD8 infiltrate. Some changes as per the biopsy. This is a characteristic inclusion body myositis here. As far as inclusion body myositis is concerned, this typical inclusion body that you see, you might not confuse the nucleus, because nucleus in muscle fiber is always in the peripheral area because of glycogen. But inside, if you see in the muscle fiber, that's an inclusion body there. It's looking more of basophilic. That's why it's called a beta amyloid. There's a characteristic beta amyloid inclusion body with the rimmed vacuoles, and very characteristic, again, of inclusion body myositis. Here also, there is no significant inflammation, but you're seeing fascicles are going for atrophy. You see one fascicle is very, very small. Another one is very big. So this size discrepancy always tells that there is a significant atrophy going on. So some basic difference in biopsy. So in exam, you see encounter a word called perifascicular inflammation, perifascicular atrophy. Always go towards a dermatomyositis or significant vascular involvement, capillary preponderance or vascular preponderance. So always go towards a dermatomyositis diagnosis. It's one disease that is actually having a vascular damage. That's why even in eightfold capillaroscopy, you are basically seeing the dropouts and tortuosity and all these problems. And this is a muscle MRI. And if somebody asks you whether MRI is important or not, it's not important for diagnosis, but MRI can tell you the area of significant inflammation. For example, in this particular patient, I'm having a significant amount of inflammation in probably in the quadriceps area. So I can tell that probably, this is the correct site for biopsy. So MRI will guide you for the biopsies. There is significant inflammation in particular area. If you take biopsy from that particular muscle, the findings are going to be more prominent. So in that way, MRI may be helpful, but apart from that, MRI is not really helpful for establishing the diagnosis. Even an injury to the muscle, even a traumatic injury can mimic something like that. So my MRI is not specific, but it will guide you the site for a biopsy, appropriate site for biopsy. Fine. So now we know the differences, and now we know the similarities as well. Now we need to know the myositis specific antibodies. There are so much of antibodies that are typically myositis specific, and currently exams, they are actually concentrating on the antibodies only. That's why I'm telling almost all the antibodies that are already there. The first myositis specific antibody that we need to discuss is on the synthetase antibodies. Synthetase antibodies. Remember, it's the antibodies that give rise to the particular clinical manifestation, as opposed to the previous belief that these disorders are different and the different disorders will result in different problems. But now we know that this presence of antibodies will dictate the clinical manifestations. So first is the synthetase antibody. As far as the synthetase antibodies are concerned, they produce a group of syndrome called synthetase syndrome. Synthetase syndrome. And there are some special features. There are some specific clinical findings that happen in the setting of synthetase syndrome. For example, they can result in myositis. In fact, the myositis will be a little severe, and most of them will be of a polymyositis phenotype. So you can ask me how it is polymyositis, dermatomyositis. When you do a biopsy, we'll see most of the cases that is associated with synthetase syndrome will be having a polymyositis phenotype only. And they can develop interstitial lung disease. They can develop arthritis. They can develop Raynaud's phenomenon. They can develop fever. And they can develop a particular skin manifestation called as mechanics hands. So these are very characteristic features of a synthetase syndrome. Whenever in exam you see only myositis with a significant ILD, so patient is having ILD and myositis together, in that setting, please diagnose synthetase syndrome, because they are trying to actually make you diagnose the synthetase syndrome only. Don't diagnose anything else. And what are basically synthetase antibodies? These antibodies are actually called as anti-aminoacyl tRNA synthetase antibodies. There's an enzyme, isn't it? That is amino acid tRNA synthetase antibodies. So there is an enzyme called amino acid tRNA synthetase. Against this only, these antibodies will be formed. So the antigen here is the amino acid tRNA synthetase enzyme. So that helps in loading the tRNA with a particular amino acid. We know that that's a transfer RNA. So that's amino acid tRNA synthetase antibody. So this amino acid group can be anything. So anything. So which means we have variety of amino acid tRNA synthetases. So which is important for transferring particular type of amino acid. So against what amino acids it can be targeted. So for example, it can be against histidyl tRNA synthetase enzyme. So that antibody will be called as anti-histidyl tRNA synthetase antibody. So this histidyl tRNA synthetase antibody is what we refer to as a Jo1 antibody. I told you this is a group of antibodies. So depending on what like amino acid tRNA synthetase it's targeted, the name will be different. So against histidyl tRNA synthetase means it will be called as Jo1 antibody, or it can be against the threonyl tRNA synthetase, that's called anti-PL7. Similarly, you have many things. You have something called anti-alanine is there. Against alanine tRNA synthetase is there, that is called as PL12. And we can have anti-isoleucine also. Against isoleucine tRNA synthetase, that is called as OJ. And we have against glycyl compound, that is glycyl tRNA synthetase, that is called EJ. And you have against asparaginase, that is called KS. So I can write asparaginal tRNA synthetase antibody, that's called KS. And we have against tyrosine tRNA synthesis antibody, that's called HA. And we can have phenylalanine against phenylalanine tRNA synthetase also, that's called ZO. So we have multiple different antibodies like that. So don't get like threatened by seeing a variety of antibodies like that. So instead, just understand that histidyl is going to be the most important for exam. You know what histidyl tRNA synthetase antibody are going to produce? They are going to produce that kind of cytoplasmic DNA staining. That is a kind of a speckled pattern which we saw already. That's why I told you there itself. I think you remember that anti-Jo1 antibody there. So histidyl is the most important, of course, of all. The remaining are very, very low yielding. Apart from anti-Jo1, the remaining are very low yielding. Remember, Jo1 is going to be the most common synthesis antibody that is seen in myositis patients, approximately by 20 to 30%. That's the highest. Among all the myositis patients, Jo1 is the most common, 20 to 30%. So you have different names. So I mean, any antibody, if it is present, and even each and every antibody has some special feature, which means which will produce more myositis, which will produce more ILD. Even that kind of categorization has been done in many rheumatology textbooks. But I don't think that makes sense as far as the UG or PG exam is concerned. So it's only about knowing one antibody, there's anti-Jo1, and knowing that there is something called a synthetase syndrome is important. What are the components of synthetase syndrome? In exam, if there is a synthetase syndrome, by chance, how will you diagnose it? Whenever the patient is having a severe myositis, along with it, if the patient is having that kind of severe ILD. So this combination always should prompt you to think towards a like synthetase syndrome. And apart from that, we have a second antibody. That second antibody is something called as anti-MDA5 antibody. Anti-MDA5 antibody, or otherwise referred to as something called a anti-CADM 140. Anti-CADM 140 antibody. CADM 140 antibody. Siddharth is asking in in synthetase syndrome whether it is polymyositis or dermatomyositis. I clearly told you, it is polymyositis that is common, not dermatomyositis. Dermatomyositis is not common in synthetase syndrome. The feature will be polymyositis feature only. I don't know what is the confusion. Okay, so then we have something called an anti-MDA5 or anti-CADM 140 antibody. So this itself is like the name itself is telling. So both are same antibody, only different names. CADM stands for clinically amyopathic dermatomyositis. That's called a clinically amyopathic dermatomyositis. So why it is called amyopathic dermatomyositis? Because these patients will not have any muscle involvement, but they will have only skin involvement. Only skin involvement that is specific for dermatomyositis. So skin involvement that is characteristic of dermatomyositis only will be there in these patients, and they won't have any kind of muscle involvement at all. So this is what we refer to as a clinically amyopathic dermatomyositis. And they can result in significant development of interstitial lung disease over a period of time, and they are not going to have good prognosis also. And there is another antibody that is called anti-TIF1 gamma, or otherwise referred to as anti-P155-140, P155/140. Both are same antibodies only, again like CADM140 and MDA5. So this antibody is the one that is associated with malignancy, that is resulting in myositis as a PNS. So malignancy-related myositis, if they ask you what antibody, that is anti-TIF1 gamma or anti-P155/140. So most common type of cancer that is associated with this kind of myositis is ovarian cancer. Ovarian cancer. Clear? And there is another antibody that is called anti-MI2 antibody. So anti-MI2 antibody is associated with dermatomyositis, especially one important sign in dermatomyositis is called as Schall sign. So that is associated with this anti-MI2 antibody. I think I've told about this also in the previous lecture itself. This antibody is one thing that is associated with a good prognosis, decent prognosis, reasonably good prognosis there with this particular type of antibody. That is anti-MI2 kind of an antibody. So then you have something called anti-NXP2 antibody. That's called NXP2 antibody. This antibody is associated with two things. One is juvenile dermatomyositis, and second thing that is associated with something called the development of calcinosis cutis. Remember, anti-P150/140 can also be associated with juvenile dermatomyositis. Suppose if in children, if it is the case, that's associated with juvenile dermatomyositis. In adults, usually that is associated with malignancy causing myositis. So now we can understand that original Bohn and Peters classification is completely satisfied, isn't it? So if you go to the prior Bohn and Peters classification, where is that we have seen? Now we know it's the antibody that is creating these clinical differences. For example, if it's a malignancy-associated myositis, then I can think about this P150/140, that is TIF1 gamma antibody. If it's a juvenile dermatomyositis, I'll be thinking about anti-P155/140, or I can think about anti-NXP2 antibody. So it's very clear that it's the antibodies that are creating these kind of clinical differences. It's not the disease itself is having different phases. So it's all about the antibody as far as rheumatology is concerned. Similarly, in adult polymyositis, you can have different kinds of antibody. In adult dermatomyositis, you have different kind of antibody. For example, the synthetase antibody can be commonly seen in polymyositis. MI2 antibody can be commonly seen in dermatomyositis. And there are many other antibodies that can be associated with CTD-related myositis. I mean, that's a completely different entity, isn't it? For example, we have an antibody called anti-PMSCL antibody. That is polymyositis scleroderma overlap antibody, which can be associated with scleroderma myositis overlap syndrome. So I'm telling some examples. So it's the antibody that's going to result in the development of a particular clinical feature. So as opposed to what we thought in the beginning, that it's the disease itself as having different phases. Apart from that, these are the important antibodies, of course, we know. But what are the cancers that can result in dermatomyositis? I told you one most common cancer is ovarian cancer, but there are a few cancers that can result in the development of dermatomyositis. What are the cancers? Apart from ovarian, you can get with breast cancer, you can get with sort of a melanoma, you can get with colon cancers, you can get with the non-Hodgkin lymphoma. So these are other cancers that can cause malignancy-associated myositis. But of course, in exam, the most important is the ovarian cancer. That's going to be the most common cancer associated with myositis. Then we have a group of antibodies that can result in something called a NAM. That's called a necrotizing autoimmune myositis. So in what way NAMs are going to be differing from the idiopathic inflammatory myositis? NAMs will be having more pain. So in the setting of pain, so NAMs are going to be a little more significant in this setting. So that's why I told you, whenever the patient is having severe pain, think about necrotizing autoimmune myositis as one of the differential diagnoses. In idiopathic inflammatory myositis does not cause severe pain. So if the pain and tenderness is very severe, so think about other alternative possibilities. In this case, the pain is very important feature of a NAM. Then at the same time, if you see biopsy, in biopsy, you will be seeing more of a necrosis. Necrosis will be more compared to the of inflammation. Actually, there will be reduced inflammation, but the necrosis will be more. Overall, these patients tend to experience a poor prognosis overall because they don't respond that much to steroid therapy as well. And this development of NAM is associated with certain antibodies. So what are the associations? What are the antibody associated with NAM? The first antibody is something called an anti-SRP antibody. That's called an anti-signal recognition particle antibody. SRP stands for signal recognition particle. Usually SRP is associated with more of a polymyositis than dermatomyositis kind of a picture. And usually that will be associated with very severe myositis. As I told you, it will be very severe because there will be severe necrosis compared to the of inflammation. And at the same time, they will be having associated cardiac involvement as well. So cardiac involvement, severe myositis is characteristic feature of a anti-SRP antibody, anti-signal recognition particle antibody. And second, we have something called an anti-HMG-CoA reductase antibody. Anti-HMG-CoA reductase antibody. And you might be thinking that is associated with statin use, but no, statin use is not associated with anti-HMG-CoA reductase antibody. That's a very common question. And they can also result in development of necrotizing autoimmune myopathy. And third one, we have an antibody called as anti-200/100 antibody. So this is the antibody that is typically associated with statin exposure. So not all patients with statin exposure will develop this anti-200/100 antibody. Only few patients with statin exposure may develop this anti-200/100 antibody. And as I told you, typically inclusion body myositis will not result in development of, in exam you should not answer antibodies are there, but there are some two antibodies that have been described in the last 1 decade. So one antibody is that anti-MUP44 antibody, number one. So MUP44 is the first antibody that has been described even in sporadic inclusion body myositis. And the second one is anti-cytoplasmic 5' nucleotidase antibody. Cytoplasmic 5' nucleotidase antibody. So these are the two antibodies that have been described for even sporadic inclusion body myositis. So we have seen a different sets of antibodies here. So right from our synthetase antibodies to MDF5, TIF1 gamma, MI2, NXP2. Then we have the NAM antibodies also, that is SRP, HMG-CoA reductase and 200/100, and we have the inclusion body myositis antibodies also in the form of MUP44 and your cytoplasmic 5' nucleotidase antibodies. Of course, yes, we have seen almost all the antibodies right now. And treatment-wise, you're going to give immunosuppression only. So for example, if you have a ILD with myositis, suppose situation number 1 is ILD with myositis, very common scenario. So in this kind of a situation, you can use a calcineurin inhibitor. For example, a tacrolimus might be helpful in this situation. Suppose if there is a refractory dermatomyositis, there is one treatment that is, apart from steroids, I'm talking about steroids anyway you're going to use. Apart from steroids in refractory refractory dermatomyositis, you can use IVIG. That could be exam question, which may be helpful in this situation. In the setting of refractory polymyositis or dermatomyositis, there is one more option that is available, that is rituximab, because you clear the antibodies by giving rituximab, the situation might get better. Similarly, another treatment option is there. Even ACTH or corticotropin has been supposed to be beneficial in the setting of a refractory polymyositis or dermatomyositis. So these are 3 treatment options. Apart from the steroids, I told you steroids are the mainstay of treatment and you have to suppress the inflammation. There's no doubt about that. But apart from what we are using, in cases of severe ILD with myositis, calcineurin inhibitors has thought to be a little beneficial. Refractory dermatomyositis, you can even try IVIG. Refractory dermatomyositis or polymyositis, you can try rituximab or ACTH. So, but steroids, immunosuppression is going to be the mainstay. If you know that much, at least in exam, that's going to be more than enough. Whereas necrotizing autoimmune myositis and sporadic inclusion body myositis will not respond to immunosuppression that much, and they are going to carry a little bit poor prognosis. And since these patients will be on steroids for a long time, there are two things that you need to differentiate. So these patients can develop steroid-induced myopathy, number one, because these patients will be exposed to long-term steroids. So they can develop steroid-induced myopathy itself, or they can develop a polymyositis exacerbation. Very common. Dermatomyositis exacerbation will have relapse of skin lesion. So that is easy to find out. So that's not a problem. But or they can have an exacerbation of myositis. There are two different principles are there. So how will you differentiate these two things? First of all, when you take a creatine phosphokinase, in a true exacerbation, it will be definitely increased. Whereas if it's a steroid-induced myopathy, it will be typically tend to be normal. There won't be any difference. So that's the first investigation that we do. Because steroid-induced myopathy itself can result in significant weakness. At the same time, in biopsy, definitely if you are still confused, you can take a biopsy where you're going to see a significant increase in inflammation if it's a polymyositis exacerbation. Whereas if it's going to be a steroid-induced myopathy, because steroids suppress inflammation, you're not going to have any kind of inflammation. But more importantly, one finding they will be asking, that is atrophy of type 2B fibers. Fast twitch fibers, that type 2B fibers atrophy will be there, or you can simply call it as a type 2 fibers. Inflammation will be very much reduced, or inflammation will not be absent at all. There are multiple ways to find out the difference between type 1 versus type 2 fibers, but steroid-induced myopathy typically affects the type 2 fast twitch fibers very characteristically. So that's the typical type of fibers that steroids will affect, and they would have been atrophied, and that can be easily found out through ATPase staining at pH of 9.4. And you would be studying all those in physiology, so I don't want to repeat that, and that's a very low yield information also. So atrophy of type 2B fibers is the important question as far as steroid-induced myopathy is concerned. Clear? So what are the difference between type 1 and type 2 fibers? I mean, I don't want to write actually, because that's a typical physiology level topic. So what is the difference between type 1 and type 2 fibers? What is type 1? Okay, let us assume type 1 is red or type 2 is red. Which is red type fibers? Which is red type? Type 1 or type 2? People are there or not? People are there, but they're not able to answer. So which means you don't know what are type 1 and type 2. That's the answer. So yeah, type 1 is basically red. Type 1 versus type 2. Type 1 is basically red type. Type 2 is basically white type. Type 1 is slow twitch fibers. Type 2 is basically fast twitch fibers. And as far as the glycolysis is concerned, there will be reduced amount of glycolysis going in type 1 fibers, whereas type 2 fibers concerned, there will be significant amount of glycolysis going on. And type 1 fibers will be having very abundant mitochondria, whereas type 2 fibers will have a sparse mitochondria. Okay. Riju is thinking that it's simple, so he wasn't answering. So you need to answer. Okay. So now I'm going to ask one question to Riju, because Riju is telling it's simple. What will be the, like glycogen concentration? So glycogen concentration in type 1 will be low, glycogen concentration in type 2 will be high. And more importantly, if you do an ATPase staining, ATPase staining can be done at 2 pH. One is at pH 9.4 and pH 9.3. But typically, if you do at a pH 9.4, ATPase staining, that is very characteristic. Usually in the type 1 fibers, it will stain light, whereas type 2 fibers will stain dark. So this is very typical of type 1 versus type 2 fibers. And this is how, because that's why I told you in ATPase staining at pH 9.4, you'll be able to identify the type 2 fibers. If they have gone for atrophy, then you can tell that this is a steroid-induced myopathy. Why PM exacerbation after steroid? Maybe your steroid doses. Nirash is asking, how can PM exacerbation happen after steroid? Which means you think steroids are the gold standard. If you give steroid, the disease will control. That's what you think. What if the patient is having severe disease? What if the patient is having uncontrolled polymyositis? You think, I mean, then why you need all these drugs? If steroids are going to be that effective and you think after steroids the polymyositis will not go for exacerbation at all, then why you need these drugs then? So you can just treat with steroids itself. So these are diseases that may or may not have response properly to your basic immunosuppression. That's why you go for advanced level of immunosuppression. That because steroids cannot be given for a long time, at the same time they are not that effective as well. If you move to the, I think I don't have the type 2 fibers diagram here. Okay, fine. Nevertheless, that's okay. So I think you'll be understanding about dermatomyositis and polymyositis right now. But there are some differential diagnoses that you need to know, basically, between different conditions. So first, we are going to take the weakness. How much is the weakness? Then what will be the pain in the patient? Then what will be the CPK levels? And what will be the inflammatory markers, CRP and ESR? And what will be the biopsy finding? That's what we're going to see. So as far as the polymyositis and dermatomyositis is concerned, number one, the most important thing is the weakness. That's going to be prominent and pain will not be there. CPK elevation will be too high and the CRP ESR will be variable, but it can be elevated usually. As the biopsy is concerned, you'll be seeing typically inflammation, then necrosis. Then as you see the necrolithic autoimmune myositis, weakness will be prominent, pain also will be prominent, CPK levels will be raised, CRP ESR can be variable, and here there will be more necrosis than inflammation. And you know the pattern of inflammation also, what happens. As far as inclusion body myositis is concerned, you have weakness, of course, yes, you don't have the pain, CRP can be, CPK can be completely normal, they won't be elevated, or even if they're elevated, it will be only a mild increase will be there, not a significant increase. CRP ESR will not be elevated, it will be completely normal, and you will see inclusion bodies. Inflammation will be less, but the presence of inclusion bodies is going to be the typical finding. That's going to give the clue in exam. Then if you take another condition, thyroid-related myopathy, if it's a hypothyroidism, in that condition still you will develop a weakness, pain, variable, you may or may not have a pain, endocrine causes may or may not have a pain, CPK elevation will be there, but not that significant. And on the other hand, the CRP ESR is supposed to be normal, they won't be elevated for sure. In hypothyroidism, very minimal inflammation will be there, you don't have that much inflammation, and you can have an atrophy. And steroid-induced myopathy, we know how it's going to present. Steroid-induced myopathy, weakness will be there, pain usually will not be there. As I told you, there will be no pain in this situation. That's why it becomes a differential diagnosis for polymyositis exacerbation. And the CPK elevation will not be there, which means CPK levels will be completely normal in this setting, and ESR will not be elevated, and ESR will be normal, and typical will be type 2 fiber atrophy. That's type 2B fibers especially will go for atrophy. That's a characteristic biopsy finding. Then you have some other conditions which can produce some sort of a muscle issue, like we have something called a fibromyalgia. In fibromyalgia, basically weakness will not be there, because you can imagine this like a functional disorder. Imagine this some sort of functional disorder. There won't be any weakness at all in these patients, but they'll be telling significant muscle pain. And very characteristically, the clue in exam will be they'll be having this multiple tender points. Just put in Google fibromyalgia tender points, and everywhere, you know, like you can see different areas, they'll be having characteristic tender points. Remember, it's a functional disorder. It's basically a functional disorder, so it's not an organic disorder. So everything should be normal. CPK normal, ESR normal, muscle biopsy will be normal. You should not get any problem in the muscles. Basically, it's only a functional disorder that tells you that the patient will have only pain, nothing else. Because it's a functional disorder, treatment of fibromyalgia is completely different. It's going to be based on your psychiatric advice, counseling, and at the same time you can use drugs like pregabalin, gabapentin, and neurologic drugs you can use. At the same time, you're going to use one more drug that is approved is milnacipran. Milnacipran is another drug that is approved in fibromyalgia. But usual clue in the exam will be these tender points. That will be the clue. So everything else will be normal. There will be no problem at all in this patient. Only muscle pain. That's all. Nothing else. Tender points. Everywhere you touch, they will tell I'm having a pain. So that is typical of a fibromyalgia basically. And there is another disorder that's called PMR, polymyalgia rheumatica, which I'll be discussing along with giant cell arteritis, where again you will not have a weakness, but predominantly you will have a sort of a pain in the shoulder, remember, but typically they'll be having catasic stiffness. And this stiffness will be more in the girdle. Stiffness will be more in the girdle, especially the hip and the shoulder girdle. So pain and stiffness will be there. And you don't have any CPK elevation here. You don't have any ESR or CRP elevation, and the muscle biopsy will once again be normal. And more importantly, you need to know it is associated with giant cell arteritis. 50 to 60% of the patients may be having this headache because of giant cell arteritis. And oh my God, we didn't talk about this ESR CRP. ESR CRP may not be normal because it's giant cell arteritis. ESR CRP will have a significant elevation in this disorder also. And of course, the treatment of this disorder is like giant cell arteritis, where you're going to use steroids as a main and important treatment in this setting. So that is polymyalgia rheumatica. I'll tell you about more about polymyalgia rheumatica when I'm discussing about the giant cell arteritis in some time. So I think this must settle the debate, isn't it? As much as possible. So this should help you to understand. So what is the like different disorders that affect the muscles and how will you differentiate them? Remember, the pain is conspicuously absent in polymyositis and dermatomyositis. Usually it will not be the case. Pain will not be there. And that's what I'm substantiating this again and again, because many students think that pain is a very important feature. In idiopathic inflammatory myositis, pain may not be there. And even if it is there, it will be very mild only. That's characteristic. Clear? Okay. Now we are moving on to the next part, that is vasculitis. It's a very important segment, isn't it? Vasculitis, even though you don't encounter a lot of cases in your clinical practice, but still, I mean, in the sense like in a UG or a PG level practice, once you become a practitioner, vasculitis is a very common case. In the sense like at least monthly 1 or 2 cases you might be able to see in your hospital. If it's a high volume tertiary center, it's a good center as having a good rheumatological practice, at least 1 or 2 cases you must be able to pick up, because it's not very uncommon, not common also. It's somewhere in between. So as far as the vasculitis is concerned, we have the classification, the beautiful classification that we have as far as vasculitis is concerned. The first, the classification we call it as that Chapel-Hill consensus classification. It's not a name of the classification. This is a conference. That's called a Chapel-Hill conference. It was last held in 2012. After that, the meeting did not happen. Probably with the existing corona, I don't think the meeting will ever happen in the first place. Based on that, they classify vasculitis into 3, many categories, but the most important 4 classifications is going to be large vessel vasculitis. Then we have the medium vessel vasculitis. Then the bigger variety, small vessel vasculitis. Then we have something called a triple V, that is a variable vessel vasculitis. Probably we can put other types of vasculitis over here. So, as far as your exams are concerned, these 3 are very important: large, medium, and small. And your variable vessel vasculitis also becomes very important, especially in the setting of Cogan syndrome and Behçet's disease. So if you take a large vessel vasculitis, only 2 are there. We know that. What are they? One is Takayasu-arteritis, and second one is going to be the giant cell arteritis, otherwise referred to as a cranial arteritis or otherwise referred to as a temporal arteritis. If somebody asks you what is the most common vasculitis in the world, I'll be going for a giant cell arteritis. Giant cell arteritis is basically the most common vasculitis in the world. But remember, please understand, it is absolutely rare to happen in Indian population. It's very common in Caucasian race. It's not common in India. It is very common in Caucasian race only. Then going to the medium vessel vasculitis, we have only 2 right now. That is polyarteritis nodosa, and second one is Kawasaki disease. So both are medium vessel vasculitis. But remember, previously there was a disease called TAO. This was removed from the classification now, that is thromboangiitis obliterans, otherwise called as Buerger's disease. Then we had something called primary Raynaud's. This was also removed from vasculitis because we believe it's not inflammation of the vessel. It is basically a functional problem in the vessel in response to cold or stress. So that's why we have removed this primary Raynaud's, and it is no longer considered as a vasculitis. And there is another vasculitis called primary CNS angiitis, which means it's an idiopathic central nervous system vasculitis called as primary CNS angiitis. Now it's been relocated to a different place called single organ vasculitis. So now primary CNS angiitis is not in the medium vessel vasculitis classification. It is relocated to a different area called as single organ vasculitis. Nevertheless, so now only we have two medium vessel vasculitis. One is Paulitis nodosa and second is Kawasaki disease. It's good for us. Then we have small vessel vasculitis. Small vessel vasculitis is a huge topic. It's basically differentiated into two basic entities. In fact, three we can tell, but to understand we can tell two. So one is the classic ANCA related vasculitis and second one is non-ANCA related vasculitis. So non-ANCA related, again you can split into two. One is without immune complex, which means you don't have immune complexes. Then second, you have immune complexes with immune complex formation. So without immune complex or with immune complex. Without immune complex, you have only one, that is Goodpasture syndrome. With immune complexes, you have many. In that itself, I can split into IgA related immune complex, that is Inoxaline purpura. Then you can put non-IgA related vasculitis. Like for example, we have a cryoglobulinic vasculitis, or I can write hypocomplementemic urticarial vasculitis, that is HUV. HUV stands for hypocomplementemic urticarial vasculitis, a form of cutaneous vasculitis. And we have another form of vasculitis called cutaneous leucoclastic vasculitis, which we'll see later on. And ANCA-associated vasculitis, you can split into granulomatous varieties. So I will remove this just to make some space. So ANCA-associated vasculitis, I can split into granulomatous forms and non-granulomatous forms. Non-granulomatous forms, we have only one, that is microscopic polyangiitis. And non-granulomatous forms can be again classified into eosinophilic types and non-eosinophilic types. Eosinophilic types will be called as EGPA, that is eosinophilic granulomatous with polyangiitis, otherwise referred to as Chooks-Strauss syndrome. Non-eosinophilic types will be called as granulomatous with polyangiitis, otherwise referred to as vaginous granulomatosis, WG. Vaginous granulomatosis. So smallest vasculitis is a huge topic. So we have a lot of classification system here that's going on. As far as the variable vessel vasculitis is concerned, you have two variable vessel vasculitis, which means variable vessel means it can affect vessels of any sizes. In that, the number one will be the Behçet's. I'm an Indian, so I'm pronouncing Behçet's, but ideally it should be pronounced as Behçet. So second one, we have something called a Cogan syndrome. Cogan syndrome is also considered to be a variable vessel vasculitis, which can involve vessels of variable sizes. And as far as other vasculitis is concerned, so we have single organ vasculitis. The best examples, many are there in this. The best examples is primary CNS angiitis, which is put under single organ vasculitis. Previously, it was a medium vessel vasculitis. And second, we have something called a cutaneous leucoclastic vasculitis. Remember, it's a small vessel vasculitis, immune complex vasculitis, but limited to the skin only. So that's why it's a single organ vasculitis. Then we have a CTD related vasculitis. So we know that SLE can produce, scleroderma can produce, rheumatoid arthritis can produce. A lot of vasculitis can, a lot of CTDs can produce vasculitis, we know that. So for example, if you take systemic lupus erythematosus can produce vasculitis. And we know an antibody, we have talked about, which can produce vasculitis, anti-dsDNA. So I think yesterday I've explained that also. So that's CTD related vasculitis. And number 3, if you want to tell, infection related vasculitis are there. It's called infectious vasculitis. So many classifications are there in that. HCV can produce vasculitis, hepatitis B virus can produce vasculitis. So many infections can cause vasculitis. So this will come under others. But each and everything has been mentioned in the Chapel classification. But for our exams, what are the important things? We need to know Takayasu, we need to know giant cell, we need to know PAN, we need to know Kawasaki, we need to know EGPA, we need to know GPA, we need to know microscopic polyangiitis, we need to know HSP, cryo, then we need to know Behçet's, we need to know, that's all. So these are the important topics for exams. Goodpasture we will discuss in nephrology because it's more of a kidney. If you want to discuss, we can discuss here, but it's more of a nephrological area. So these are the different types of vasculitis. Whatever I underlined in blue color, that's going to be important topic for exams. to discuss in the first place. So first, it's important to differentiate the different forms of vasculitis. In the sense, like we have to differentiate into primary, the large, small versus medium. What are the basic differences between them? That's what we need to know. Then we have to have a discussion on ANCA. Then after understanding ANCA, then we'll move on to the explanation of each and every different types of vasculitis. So then at a basic level, so once we know the classification properly, then as a basic level, we need to know the differences between a large vessel vasculitis, a medium vessel vasculitis. And a large vessel means we have two vasculitis in that. One is the giant cell arteritis and second is the Kawasaki disease. Takayuki arteritis. Takayuki arteritis. In medium vessel, we have the PAN as the most important. Kawasaki is a completely different entity, which we'll be discussing later on. Then we have the small vessel vasculitis. In the small vessel vasculitis, I can split it into two. I can tell ANCA associated small vessel vasculitis and immune complex related small vessel vasculitis. So we need to know the differences, how they are going to get involved in different areas. So the first one is going to be the vessel that is affected. So what will be the vessel that is affected in a large, medium, and small vessel vasculitis? Whatever may be the case. So the most important vessel that is affected in a GCA or Takayuki arteritis, whatever may be the case, it's aorta and its branches. Aorta and its branches are the vessels that are typically affected in the setting of a large vessel vasculitis. Its ability to affect aorta is the reason why the name has been called as large vessel vasculitis. But remember, the most common vessel affected is different. In giant cell arteritis, it's superficial temporal artery, otherwise referred as STA, whereas in Takayuki arteritis, it is the subclavian artery. Subclavian is the most common vessel that is affected, subclavian artery. Whereas in giant cell arteritis, most common vessel affected is the superficial temporal artery. As far as polyarteritis nodosa is concerned, usually they will be affecting the medium-sized vessels, which means the the end organ vessels. Or I can not end organ, that's not the right name, organ-related vessels. Organ-related vessels. So organ-related in the sense like they might be affecting the renal vasculature, mesenteric vasculature, coronary vasculature. So these are vessels that are supplying the organs. So these organ-related vessels, if they are affected, that is typical of a medium vessel vasculitis, especially PAN. So in this case, it can affect the renal or the mesenteric vasculature, which is the one that will be very commonly affected in this setting. So as far as the ANCA is concerned, ANCA is like an overlap. It can affect medium as well as it can affect small vessels also. But since it's predominantly concerned with small vessel, it's put under small vessel vasculitis, but it's like an overlap. It can affect both medium as well as small vessels. And as well as the immune complex vasculitis is concerned, typically they're going to affect small vessels like capillaries, venules, arterioles. So these small vessels are the ones that will be damaged in the setting of an immune complex vasculitis. So they are typically small vessel vasculitis. They don't cause any involvement of the larger vessels. And there will be a substantial overlap. But remember, when you diagnose vasculitis, we didn't talk about that at all. So when you will have a suspicion of vasculitis, which means when you can think about a vasculitis. Number one, whenever you have a vasculitis, think about a vasculitis, the patient will have definitely constitutional symptoms because it's inflammation. Second is elevated inflammatory markers like CRP, ESR. These are usual features of all the vasculitis. All the vasculitis will have some constitutional features. All the vasculitis will have elevated inflammatory markers. And at the same time, you'll be resulting in like multiple organ involvement most of the time. So it will not be like a particular single organ involvement. Most of the time, it will be a lung, kidney together will be involved, brain, lung together will be involved, or you have a kidney and heart together involved. So there will be a multiple organ involvement. Multi-organ involvement, at least more than or equal to 2. So in that setting, you can suspect a vasculitis. And at the same time, when you do a biopsy, there will be a vessel wall inflammation. Vessel wall inflammation will be there. So these are the areas where you generally suspect vasculitis. So this is the characteristic area. Like the most important clinical entity where you diagnose this is multi-organ involvement with constitutional symptoms and elevated inflammatory markers. This is not specific for vasculitis. But like in this situation, like you can suspect vasculitis as one of the important differential diagnoses. That's where it gives you the suspicion for vasculitis. Then coming on to the next, for example, if we take the age and gender distribution. Age and gender distribution, Giant cell arteritis is an extreme spectrum. It affects old age more than 50. Females are more common than males. Whereas if you take the Takai's arteritis, it affects the younger people, typically age less than 40. Once again, females more than males. So old females, giant cell arteritis, young females, Takai's arteritis. And remember, if you take the geographical distribution, Caucasians are the ones that are affected with giant cell arteritis, and Asians are the ones that are affected with Takai's arteritis. That's a very, very important point. Indians are very rarely getting affected with giant cell arteritis. It's very rare to have Indians getting giant cell arteritis. And then as far as polyarteritis nodosa is concerned, it's a variable age, but generally they'll be middle-aged group, most of them, because of Hepatitis B virus, which has significant association with polyarteritis nodosa. And there is no such gender preponderance right now. So males and females can be equal here in polyarteritis nodosa. As far as ANCA-related vasculitis is concerned, we don't really have any particular age, and immune complex, again, we don't have any particular age. Variable again. Then coming to the organ involvement, one by one. If you take the skin, that's the first organ, isn't it? To see from outside. So typically, large vessel vasculitis will not have any skin involvement, in the sense like they might have some nodular lesions in the skin, but in general, they don't have any characteristic skin involvement. But all these three will have definite skin involvement. So for example, your ANCA-related vasculitis, immune complex vasculitis, small vessel vasculitis will have substantial skin involvement. The characteristic feature of the medium vessel vasculitis causing skin involvement is the typical livedo reticularis kind of a pattern. Whereas the characteristic small vessel vasculitis, immune complex vasculitis producing this kind of skin involvement is the palpable purpura. That's a characteristic skin lesion that happens with a small vessel immune complex vasculitis. But ANCA being an overlap between these two, they can produce livedo reticularis type of pattern also. They can produce palpable purpura type of pattern also. Which doesn't mean that palpable purpura is not common, but palpable purpura can happen in polyarteritis nodosa also. There will be a substantial overlap will be there. And at the same time, they can produce Raynaud's, they can produce cutaneous infarcts and ulcerations. All these are possible. Same, which means there will be a substantial overlap as far as skin is concerned. They can also produce Raynaud's. They can also produce ulcers. But as far as exams are concerned, when you think about an exam kind of a scenario, livedo reticularis goes towards a medium vessel, and palpable purpura generally goes towards a small vessel. ANCA, clearly you cannot tell anything. It can have both features of medium and small vessel vasculitis. So livedo, think about PAN. Palpable purpura, mostly think about a immune complex vasculitis like Henoch-Schönlein purpura. Number 4, the next organ that can be affected is the lung. Lung is very, very important organ, pulmonary involvement. As far as the large vessel vasculitis is concerned, lung is very rarely affected. Usually don't get any lung involvement at all. As far as medium vessel vasculitis is concerned, once again, lung involvement is extremely rare. You can put negative here. It's very, very rare to have. Whereas ANCA-associated vasculitis and immune complex vasculitis is concerned, lung involvement is extremely common. In fact, among all, if they ask you where the lung involvement is extremely common, I'll be talking about ANCA-associated vasculitis only, rather than immune complex vasculitis. Immune complex vasculitis, I told you 2 important immune complex vasculitis. One is cryoglobulinemia and second is Henoch-Schönlein purpura, where here cryoglobulinemia will cause more lung involvement relatively compared to that of HSP. HSP will not have that much of lung involvement. But in general, if they ask you among all the vasculitis which has the maximum lung involvement, I'll go for ANCA-associated vasculitis only. They are the ones that are going to have a maximum lung involvement. Remaining all the other things will have less, or large and medium will not even have the lung involvement in the first place. And then renal involvement, very important. As far as renal involvement is concerned, large vessel vasculitis usually will not have that much of significant renal involvement. But one thing that can do this large vessel vasculitis is they can produce aortitis. Because of aortitis, there will be reduced renal perfusion. Because of reduced renal perfusion, they can activate the renin-angiotensin-aldosterone system, and they can result in severe hypertension. But they won't produce any other problem. And in the Takai's arteritis is one entity. Takai's arteritis is one entity. Even though direct renal involvement is not there, Takai's arteritis is one entity which can have a renal artery involvement. renal artery involvement can be there. Nevertheless, both these disorders, Takai's as well as Jane's arteries, can produce aortitis. Because of that, they can produce reduced renal perfusion and they can produce hypertension. But Takai's arteritis is one disease that can directly involve the renal artery sometimes, and they can result in development of the hypertension. So that's one small difference is there. As far as the medium vessel vasculitis is concerned, renal involvement is common. Renal involvement can happen, and they also involve the renal vessels, not the renal artery. They won't involve the renal artery. Instead, they will involve that other branches. After the renal artery, you have that next generation branches that will be involved in polyarteritis nodosa, and this will result in the development of renal infarcts because that end organ vessels will be damaged. Because of that, they'll go for infarcts. And in fact, whenever they tell the word infarcts, it's very classical of a medium vessel vasculitis, myocardial infarct, Kawasaki disease, renal infarct is for polyarteritis nodosa. Infarcts are extremely common. So because of these infarcts, they can develop hypertension and hematuria because of reduced renal perfusion. And this hematuria, very important point is they will not contain RBC cause. So all these factors, especially this no RBC cause, typically goes towards a polyarteritis nodosa. As far as ANCA-related vasculitis and the immune complex vasculitis is concerned, they affect the kidney. Yes. So before putting that, I can tell kidney involvement is extremely common in ANCA and immune complex vasculitis. But in if you take this, what will be the finding? So because they are small vessel vasculitis, they are going to have involvement of the glomerular vessels. When they involve the glomerular vessels, they are going to produce glomerulonephritis. You know, what is the characteristic triad of glomerulonephritis? They will have hypertension, they have acute kidney injury, and they have hematuria and proteinuria. Hematuria, proteinuria will be there. So hematuria means definitely this hematuria will be having RBC cause. And proteinuria will be more than 0.5 grams per day or more than 500 milligrams per day. So this is characteristic of a glomerulonephritis, and which means the most important feature is here hematuria without RBC cause, here hematuria with RBC cause. Remember, because they are small vessel vasculitis, they are going to involve the glomerular vessels. They won't involve the major, bigger renal vessels for that matters. So this is point number 5. When you go for point number 6, we can talk about, how to differentiate them. Remember, only hypertension, large vessel vasculitis, hypertension with hematuria, but no RBC cause, medium vessel vasculitis, hypertension, hematuria, and RBC cause, go for a small vessel vasculitis. That's how you differentiate. Then I can have a gastrointestinal tract involvement, GIT involvement. Typically, GIT involvement is very rare. You don't really get GIT involvement in the setting of large vessel vasculitis, but still because of the aortitis, again, they can produce reduced mesenteric perfusion and they can cause abdominal pain, especially in the postprandial time. That's called a mesenteric angina. That's possible, but in general, for exam, you tell it's rare. And apart from that, GIT involvement is quite common. The setting of a polyarteritis nodosa can happen, and they can also produce the smaller vessels, the next generation mesenteric vessels after arising from the superior mesenteric artery, inferior mesenteric artery, will go for aneurysms and they go for infarcts. So they can produce infarcts again in the GIT, and they can produce severe abdominal pain, acute abdomen, and all this stuff. Abdominal pain, hemorrhage, and a lot of this stuff. As far as small vessel vasculitis is concerned, again, abdominal involvement can happen in the setting of a ANCA-associated vasculitis very commonly, especially with Chokes-Strauss syndrome, extremely common. And as far as the immune complex vasculitis is concerned, it can happen, but it happens more with the henoch-Schönlein purpura than a cryoglobulinemia. It's very common with HSP than cryo. So pulmonary involvement is more common in cryo than HSP, whereas GIT involvement is more common in HSP than cryo. Because if you take henoch-Schönlein purpura, one triad is there. In that, the most important is the abdominal pain. More important is the abdominal pain. Then you have the 7th. What is the neurological involvement? Neurological involvement as such is rare in the setting of large vessel vasculitis, but nevertheless, because of the aortitis again, they can cause reduced perfusion to the brain, which can result in stroke and transient ischemic attacks. But direct neurological involvement is not very common in the setting of a large vessel vasculitis. On the other hand, In medium vessel vasculitis, neurological involvement can happen. So there are two forms of neurological involvement. Direct CNS involvement can happen, which can produce strokes. It's a direct involvement of the brain vessels. They can cause strokes, altered mental status, confusional state, and all this stuff. And at the same time, they can produce peripheral neuropathy. So both are possible. And one more important thing that is characteristic of a medium and small vessel vasculitis is the fact that they can produce something called a mononeuritis multiplex. We know what is mononeuritis multiplex. I have explained in detail in the CNS chapter itself. Then ANCA-associated vasculitis, very characteristic is mononeuritis multiplex. This is extremely characteristic. Usually they don't produce that much of peripheral neuropathy, but this mononeuritis multiplex is extremely characteristic of ANCA-associated vasculitis. So that should be the key for exam. And as far as your HSP is concerned, they more often produce a peripheral neuropathy, which will be of a small fiber type or axonal type, as far as the immune complex vasculitis is concerned. So this is a neurological involvement, but quite confusing. But I mean, all of them literally can produce kind of a stroke TA, but ANCA-associated vasculitis is typical of a mononeuritis multiplex and more of a polyneuropathy in the setting of a immune complex vasculitis. When you do a biopsy, when you're going to do a biopsy in the sense, the most important is to see whether the granulomas are there or not. So remember, all these are granulomatous inflammation. So you will see granulomas in the setting of a large vessel vasculitis, but in PAN, you will not see granulomatous inflammation. It's more of a fiber node necrosis. You don't see granulomatous inflammation, whereas in immune complex vasculitis, it depends. You don't see granulomas in the setting of immune complex, but in ANCA-associated vasculitis, you generally see granulomas. So I can write no granulomas here. But typically, you will see granulomatous inflammation in ANCA-associated vasculitis. But one thing that does not show granulomas is microscopic polyangiitis. So that is why I think in the beginning, when we classified itself, we are very clear that microscopic polyangiitis does not have a granuloma. That's why it differentiated. Even though it's ANCA-associated vasculitis, the only thing that does not have granulomas is the microscopic polyangiitis. That's why I mentioned that point here. ANCA-associated vasculitis can have granulomas, but except one thing, that is microscopic polyangiitis. And number 9 is the angiogram. You do a CT or an invasive angiogram, doesn't matter. Angiographic findings are extremely common. Typically in a large vessel vasculitis, you see this vessel wall thickening. Vessel wall thickening, plus or minus kip areas will be there. There are some areas which will be involved, some areas will not be there. That will be the typical angiographic finding here. Either invasive or a CT angiography, doesn't matter. As far as the medium vessel vasculitis is concerned, typical is a aneurysm formation. Microaneurysm in the setting of a PAN, very characteristic, but in Kawasaki you can see this bigger giant macroaneurysms also. But nevertheless, aneurysm formation is very typical of a medium vessel vasculitis. Micro in the setting of PAN, macro in the setting of a Kawasaki disease. But in the setting of small vessel vasculitis, angiogram is going to be completely normal. You don't see any finding at all because small vessels cannot be seen by angiography in the first place. You cannot see angiography. You cannot see, any finding in angiography. 10th, miscellaneous findings. So giant cell arteritis, it's more of a headache and jaw claudication and a sort of a blindness. So this is a problem in giant cell arteritis. And as far as your Takai's arteritis is concerned, it's more of a arm claudication rather than a your jaw claudication, and more of a absent radial pulse. Absent radial pulse, that's characteristic of a Takai's arteritis. As far as polyarteritis nodosa is concerned, you're going to get more of a multi-organ involvement. Multi-organ involvement that will be very characteristic in polyarteritis nodosa, and most important clue in exam will be sometimes HbA1c positivity. In 10% of the cases you can have HbA1c positivity, not all the patients, but that could be the clue in exam, HbA1c positivity. And As far as ANCA-associated vasculitis is concerned, the most important is ANCA positivity. It could be a C ANCA or P ANCA. If it is C, think about vaginous granulomatous. If it's P, think about a microscopic polyangiitis or a Churg-Strauss syndrome. So ANCA positivity is the key for diagnosis here. And one other key for diagnosis is the involvement of lungs and kidneys together. That's called a pulmonary renal syndrome. Whenever you have a lungs and kidney involvement together, think about like ANCA-associated vasculitis. If you have a prominent ENT involvement, think about a vaginous granulomatous. That is granulomatous with polyangiitis. That's one point that you need to know. And apart from that, if you think about immune complex related vasculitis, the skin involvement is going to be the prominent one. Typically, if you see a palpable purpura, that's going to be a classic. So that will be the other thing. And typically they will be ANCA negative and they will not have any ANCA positivity. They will be usually ANCA negative only. And if it's a cryoglobulinemia, usually examiner will give a HCV, hepatitis C virus clue, because single most important cause of cryoglobulinemia in the world currently is hepatitis C virus only. So if it's a cryoglobulinemia, always the examiner will give a clue of hepatitis C virus. So that's the clue there. Miscellaneous findings. And apart from that, treatment as far as the giant slat is concerned is steroids, and even in Takayasat it's going to be steroids, but even though other immunosuppressive agents are there, usually treatment for polyarteritis nodosa will be based on 5-factor score. Treatment for ANCA is variable, and again treatment for Churg-Strauss syndrome, your immune complex vasculitis is steroids plus or minus higher level of immunosuppression. Other immunosuppressive agents is what you're going to use. So this is a master chart. Even though there is a substantial overlap between each and everything, this this tabular column and this chart should be able to provide a good idea about how will you really differentiate different forms of vasculitis, large, medium, as well as small vessel vasculitis, and what are the clues to diagnose each and everything. Suppose if you don't have sufficient time in exam to go through all the vasculitis in detail, so just go through this chart, and 95% and plus number of times you will be able to identify the type of vasculitis just using this chart. That must be more than enough. Clear? As far as I know, in the entire vasculitis, this chart becomes the most important one. Do you understand? I think I've given all the clues. Whatever you need for exams, it's there in this chart. That's all. Nothing more is required. And we have to anyway discuss about each and every individual types of vasculitis, of course. Let us discuss about each and every different type of vasculitis. Start from the large vessel vasculitis, start from the small vessel, then to the medium vessel vasculitis, then finally to the small vessel vasculitis. First, large vessel vasculitis that we're going to discuss is going to be on the giant cell arteritis, GCA. That we're going to discuss first. Giant cell arteritis, GCA. So as far as the giant cell arteritis is concerned, we know it's going to be extremely common in females, age more than 50 years, typically a Caucasian disease, very rare in Indians. And as far as the giant cell arteritis is concerned, most common symptom in giant cell arteritis patient is going to be the headache. And of course, it's important that you tell the characteristic features of this headache. And before that, let us see the arteries that will be affected by giant cell arteritis. So headache is the most common symptom and usually be the temporal location. Siddha is asking, want to take screenshots. I gave sufficient time to take screenshots, but you can actually, once the video is uploaded again, you can take the screenshots, not a problem. If I go again, it will be a lot of time wastage. So most common symptom is going to be the headache. And what you're talk about, I just got distracted suddenly. In the sense, like, we need to know the vessels that are affected by giant cell arteritis. As far as the vessels is concerned, the first and the most common vessel we know it's the superficial temporal artery, and that is the reason why you develop headache in the first place. And then after this, very common vessel that will be affected is a facial artery. That will be a very common vessel that will be affected. So involvement of this facial artery is the one that leads to a very specific symptom of giant cell arteries that's called as jaw claudication. That's the most specific symptom as far as giant cell artery is concerned, getting a jaw claudication. And apart from that, you can get involvement of the other vessels. For example, slowly it can move to the ophthalmic artery. So once the ophthalmic artery is starting to get involved, you will result in involvement of the poor perfusion to the central retinal artery and will result in an AON-like picture. This type of AON is called as arteritic type of AON because it's due to giant cell arteritis, and that will result in blindness. And the most important problem with this good thing about this blindness, it is the fact that it is a completely preventable cause of blindness. But if you if you miss the bus, it becomes irreversible. Irreversible once happen. In the sense, you can prevent beforehand itself, but once happens, it is supposed to be irreversible. You cannot reverse that, but it's preventable. So that's the good thing and the bad thing. Good news and the bad news with regards to blindness in giant cell arteritis. One of the important globally preventable cause of blindness, giant cell arteritis in elderly people. And apart from that, slowly it starts involving the aorta and its branches also. It also can be involved. That will be seeing subsequently what will be the effects. For example, because they cause severe aortitis, they can result in aortic dissection, all this stuff. I'll tell you in some time. So first, let us characterize the headache. So what will be the feature of this headache in patients with giant cell arteritis? Number one, headache is the most common symptom. We know that in patients with giant cell arteritis. And second, of course, headache is going to be the clinical features. The clinically speaking, headache will be of throbbing type. Don't diagnose migraine. It can be typically unilateral and throbbing. So sometimes you might be falsely thinking it's a migraine because it happens in the temporal location very characteristically. So remember, elderly patient, a new onset headache, always it's something serious. You should not take it as a migraine. Primary headaches. Primary headaches happen in younger people. Older people, new onset headache, don't diagnose a primary headache unless proved otherwise. So any elderly patient coming with headache, you should evaluate detail. It could be a tumor also, it could be giant cell arteritis, it could be anything. So when you examine this patient, they'll be having tenderness. So when you examine these guys, they will be having tenderness in the temporal area, and the temporal artery will look thickened and cord-like, and it will be most often pulseless. You have a thickened, tender, cord-like and a pulseless temporal artery. That is very classical of a like giant cell arteritis. And very commonly you will see these kind of images. So this is a very classic image that they will give you in exams. You can see this kind of thickened, tender, serpentine cord-like temporal artery, which will be extremely tender to touch, and they'll not have any pulse. That's a very classical picture that you get in exam in a patient with a giant cell arteritis. And as far as jaw claudication is concerned, it is due to ischemia to the jaw muscles, especially the muscles of mastication. So that's why you get this jaw claudication. As far as this anti-ischemic optic neuropathy is concerned, you know what is a typical type of picture that you generally tend to get in AON. If they ask you the type of visual field defect that you get in AON, that is a kind of an altitudinal defect. So, this is very characteristic. If they ask you most common kind of visual field loss or visual defects that you get in patients with arthritic type of AON or any AON for that matters, anti-ischemic optic neuropathy for that matters, it is going to be like altitudinal kind of a defect. So usually the most important artery that gets affected in the setting of a giant cell arteritis is the posterior ciliary vessels. Posterior ciliary arteries or posterior ciliary vessels, those are the ones that are going to be affected very importantly in the setting of a giant cell arteritis. And of course, you need to know the difference between arthritic type of AON and non-arthritic type of AON. So I gave a glimpse of all those things in the CNS itself, but just let us review. So what is arthritic type of AA1? It is due to giant cell arthritis. Non-arthritic type, it is due to atherosclerosis. Fine. So headache is a very common feature. We know that in arthritic type of AA1, whereas in non-arthritic type of AA1, you don't get headache. Headache is a very uncommon finding. And as far as the vision loss is concerned, it will be more acute vision loss. It will be more subacute in nature. It will start unilaterally and slowly, I mean, not slowly, very fast, it will become bilateral. Very fast, it will become bilateral. It will be unilateral. To become bilateral, it takes a very, very long time. So it will not really become bilateral that easily. So it will take a really, really long time to become bilateral. Okay. On the other hand, it will be severe kind of a vision loss, which means typically it will be only vision will be less than 6 out of 60, whereas it will be mild to moderate only. It will not be severe, like 20 by 60, 40 by 60. That will be the kind of severity of vision loss that you get here. And apart from that, if you see a fundus examination, you will see something called a pale edema here. I mean, disc edema. I'm talking about edema means I'm talking about a disc edema here. You'll have a pale edema. Here we call it as a red edema, which means this usually will be associated with erythema, hemorrhages, especially flame-shaped hemorrhages. All these things are quite common in the setting of a non-arthritic type of AON. That's really, really important again. And here something called, like central bright spot sign. I mean, that's been thought to be, like one of the features of giant cell arthritis for sure. Let me show you what is that. That's called a central bright spot sign in MRI. Central bright spot sign that is seen in both, but more than 95% of the cases of arthritic type of A1 will have the central bright spot sign, but only 70% of the cases with non-arthritic type of A1 will have central bright spot sign, which means this sign, if it is absent, it's unlikely to be a giant cell arthritis, which means it's very common in giant cell arthritis. It's a very high negative predictive value sign. So if it is absent in giant cell arthritis patients, we generally tell that this is unlikely to be a giant cell arthritis. That's all. And as far as the treatment is concerned, you're going to use steroids for these patients. Here you are going to manage more conservatively in the sense like you'll be using aspirin, statins, and all this stuff. So that's how you manage a non-arthritic type of AON, that is anti-ischemic optic neuropathy. And as far as the gender distribution is concerned, atherosclerosis can happen in any people, females equal to males, whereas giant cell arthritis typically happens in females more commonly. So female more than male. So this is how you differentiate arthritic versus non-arthritic type of A1. So you'll be obviously asking one important question. What do you mean by bright spot sign? So you'll be able to see this kind of a central bright spot here. So in the optic nerve area. So that's what we refer to as something called a central bright spot sign. So that is seen in both giant cell arthritis as well as non-arthritic type of A1. But if it's absent, then you can think other diagnosis apart from giant cell arthritis. But if it's present, surely it's a giant cell arthritis. So for comparison, you have a normal disc here, and you have a kind of a disc blurring here. So you cannot see the disc margin very clearly. You can see the disc margins very clearly here. So this is an example of a blurring of the disc. And at the same time, if you see a giant cell arthritis, you can see more of a pale edema. So it's a margin, I mean, disc margin is not very clear. It's blurred only, but it's more pale here. But here on the other hand, if you see it's more red, here also it is blurred. It's not very characteristically, like identifiable. It's blurred here and it's more red. Here it's pale, it's red. So that more goes towards pale means it's giant cell arthritis. Red edema is usually towards a non-arthritic type of A1. And you can see a speck of hemorrhage here. Whenever you see this kind of hemorrhage, that's typical of a giant cell, non-arthritic type of A1 again, atherosclerosis induced. This is how we differentiate an arthritic type of A1 versus a non-arthritic type of A1. Nevertheless, and of course, you are going to move towards the aortic involvement. So because they can produce aortitis, they can result in a variety of problems like aortic aneurysm formation, or even they can result in aortic dissections possible in untreated and severe cases. once they start involving the arch of the aorta, the arch vessels will go for ischemia. If the arch vessels go for ischemia, they can result in arm claudication also, like that of Takayasu arteritis patients. Even the arm claudication in exam usually goes towards Takayasu arteritis only. But even this is an aortitis, so you can get arm claudication because of subclavian artery involvement, and they can result in strokes and transient ischemic attacks. Or if they start involving the coronary vessels, they can develop myocardial infarction as well. And remember, giant cell arteritis has one very important association with a disorder called polymyalgia rheumatica. So this is an associated disorder. So you might have an association with polymyalgia rheumatica. Usually polymyalgia rheumatica is a secret. So the first finding, you get stiffness, typically of the girdle. That's what you get. More of a shoulder girdle than the hip girdle. The stiffness will be there, and stiffness and pain also will be there. But weakness is not a finding. So remember, stiffness and pain will be there, but no weakness. Weakness is not a feature of polymyalgia rheumatica. Only stiffness and pain of the girdle area, especially shoulder girdle. And they might have a ESR elevation like that of giant cell arteritis. Significant ESR elevation will be there. And they also, like giant cell arteritis, will have typical constitutional symptoms like fever, weight loss, and all this stuff. Remember, all the vasculitis, as I told you, will have constitutional symptoms. And very commonly, they will have rheumatoid arthritis-like picture, which means we call it as rheumatism, which means they are going to have arthritis also. And again, like giant cell arteritis, they're very common in elderly. And similarly, they have a good association with giant cell arteritis, that is temporal arteritis. So usually that's how I used to give by a mnemonic. That's why I told you in the beginning it's a secret. So secret is a mnemonic to remember the manifestations of polyarteritis nodosa, SCCRET, stiffness and pain, elevated ESR, constitutional symptoms, rheumatism, elderly, temporal arteritis. Which means if you ask how much temporal arteritis patients have association with giant cell arteritis, there is a 50% association, which means half of the patient with giant cell arteritis may have an associated PMR. Certain patients may have a PMR alone. Now your question will be very simple. How do you differentiate a PMR versus a rheumatoid arthritis? Very simply, rheumatoid arthritis will have more of a small joint involvement. It's rare to have a small joint involvement in the setting of a polymyalgia rheumatica. Most problem will be of the stiffness of the girdle. So that's pain of the girdle. So that's going to be the most important. Small joint involvement is rare in the setting of a polymyalgia rheumatica. And even if it is there, it will be of an erosive type of arthritis. Here you will not see any erosions. And more importantly, rheumatoid arthritis will not have any association with giant cell arteritis and headache. Here you might see association with giant cell arteritis. And ultimately, rheumatoid arthritis patients will have RF and ACPA positivity. Here you don't have any serology positivity. It will be negative. So even if there is a small joint arthritis, if there is no RF and ACPA, I will generally don't think about a rheumatoid arthritis in that setting. So this is how we differentiate a RA and a rheumatoid arthritis in real setting. But remember, in exam, many of the times they will confuse you by giving a stiffness of the shoulder girdle along with the headache. So don't get confused. So which means they are giving an association with the polymyalgia rheumatica. But both giant cell arteritis and polymyalgia rheumatica are treated in a very similar way. That is steroids. Steroids are the mainstay of treatment in both rheumatoid arthritis as well as the polymyalgia rheumatica. Then what about the investigations? What investigations you can do in giant cell arteritis? So investigation wise, the most important investigation that you will be getting in exam is the ESR, acute phase reactant, because giant cell arteritis is one condition where you'll have an extremely high ESR, like even we have seen 100, 200, that kind of ESR. Usually it will be more than 50 by definition, and ESR elevation is not important for giant cell arteritis diagnosis. Some patients in literature has been described as to have a normal ESR also, less than 50 also. So don't take it as a very important thing, but almost majority, certainly 90-95% of the patients will have elevated ESR, and most of them will have a very high ESR, more than 50. And apart from that, if they're going to ask a gold standard investigation, of course, it's going to be the biopsy. Biopsy is considered to be the gold standard. And typically we take biopsy from the superficial temporal artery. Superficial temporal artery biopsy. And surgeon will do that. So no need to worry about that. So as far as the biopsy is concerned, because these large vessel vascularities are known to show the skip lesions, so it's important that you take adequate length. For example, you take a central 2 centimeter biopsy, plus or minus on either side you have to give another 2 centimeter clearance. Plus or minus you have to give another 2 centimeter clearance, which means ideally minimum you have to take 3 to 6 centimeter of length of giant cell, superficial temporal artery to make a good diagnosis. Otherwise the sample will not be sufficient. So clear, that's very important. So when you're going to take a biopsy, you should minimum of 3 to 6 centimeter or at least 2 centimeter clearance on either sides is very, very important when you take a biopsy. So number one, so this is the most important thing that you need to know because they can show skip lesions. To guide the site for biopsy, if you want to know the exact site where you need to take a biopsy, ultrasound may be helpful. So in ultrasound, you might be seeing something called a halo sign. The area where you see the halo sign is the area which is maximally affected in the setting of a giant cell arteritis. So that is the reason why ultrasound is helpful in that scenario. Maybe ultrasound will be helpful to tell the site of biopsy, not tell you the diagnosis, but it will tell you the site for taking a biopsy. Suppose if we don't have ultrasound, the area which is maximally tender and the area which is maximally pulseless, that area you can mark and you can take the biopsy. Area which is maximally pulseless or area which is maximally tender. So that will tell you the site of biopsy if you do not have an ultrasound. But of course, you do have an ultrasound, so it's very easy to pick up in that setting. So more important point is biopsy is not needed to start the treatment, which means even without biopsy, you can start the treatment. No problem, because here starting the treatment is more important than taking a biopsy because the findings in giant cell arteritis will persist even after 1 week after starting the steroids. So it's not mandatory that you need to take a biopsy and then only you should start the treatment, because this is a disease where it could rapidly progress to development of blindness. So which means your biopsy is not mandatory. Start the treatment first, then after 2-3 days also you can take the biopsy because the biopsy findings will persist even after 1 week after taking the corticosteroids. So don't wait for the biopsy or don't wait to start the treatment because the biopsy is not done. That's going to be the next treatment strategies. As for the treatment are concerned, the most important treatment is steroids. You can give steroids even without biopsy findings or even if without taking the biopsy, not a problem at all. Now in this setting, you need to decide whether it's an oral steroid or you're going to start with an IV steroid. So for that, you need to know the indications for an urgent IV steroid. So of course, there are only 2 indications. One is jaw claudication. So if it is present, definitely you have to start with urgent IV steroids because of course you are going to result in, blindness next. So jaw claudication is an urgent scenario. So you have to start with steroids. Then next is amaurosis fugax. The patient has got a threatened vision. So amaurosis fugax is otherwise referred to as something called a threatened vision. Threatened vision. So in this setting, you can give IV steroids. This indicates of urgent IV steroids or pulse methylprednisolone can be done. But apart from that, there is no indication for IV steroids. Suppose if the vision is completely gone, then in that setting, you can go for oral steroids as well. No need to really go for IV steroids in this setting. But apart from that, other options are there because steroids, you need a higher dose steroids. Whenever you give steroids, you need a high dose. So if you don't have a sustained remission, then you can try alternative drugs. Alternative drugs that include methotrexate can be tried. It's a steroid sparing agent, or you can try another drug called tocilizumab. Everyone knows tocilizumab now. IL-6 receptor inhibitor. So all these drugs can help in maintaining a remission. But most of the time, steroids, that high dose steroids that you start with, typically you start with 1 milligram per kilogram per day, typically in the range of 40 to 60 milligram. This is what we refer to as a high dose steroid. So this high dose steroid itself is more than enough most of the times, but it has to be given for a longer duration of time, like maybe sometimes 6 months, 12 months, 18 months also should be given to maintain a remission. So if the patient develops steroid related problems, then you can go for sparing agents like methotrexate or probably even tocilizumab. So not a problem at all. So this is the treatment that you're going to give for giant cell arteritis. So giant cell arteritis is a very important topic in exam. I think we have covered in detail about what are the intricacies of the giant cell arteritis. Then Takai's arteritis is quite simple. It's not very difficult to understand. There's another large vessel vasculitis. As far as Takayasu arteritis is concerned, you know very well it's going to be again a female predominant disease, but here the ratio is humongous, that is 9:1, which means it's an exclusive female disease. That's what you can talk about. And at the same time, it's going to be happening in younger individuals, less than 40 years, and it's common in Asians. But remember, overall Takayasu disease is rare to diagnose. It's not possible to diagnose Takayasu arteritis that commonly, that frequently in your practice. It's a very rare disease, affects Asians, less than 40 females, very characteristic. And very easy to find out because you're going to have this kind of absent pulse, and that's easy to find out as well in real practice. But nevertheless, there has been a probable etiological association with tuberculosis. But Western books will not give you this, but there has been thought that there is some association with tuberculosis in Asian population. That's why probably these patients are having this kind of large vessel vasculitis, because previously there has been two confusions. One, if there is a TB association, this kind of disease is called as a non-specific aortitis. That's how they called it as. If there is a strong history of TB, then yes, I've seen a lot of cases, Hari. Not a lot, two cases I have seen. One, some fat lady, I don't remember her name. She's a Christian, I think. I forgot her name basically. She's very obese and fat, 128 kilograms. That's one case I remember. And second case is another lady. So two cases I've seen Takayasu arteritis. That first lady is very typical. She's been in follow-up till now. Maybe if I remember the name, I'll tell you. I have some images about that also. I'll show you. So TB, if there is there, then they called it as a non-specific arteritis. If there is no TB association, they called it as a Takayasu arteritis. So that's how they called it. That's how they split it initially in 1999, 2000 books and all. If you see, there will be two different types of arteritis. So currently, this kind of terminologies should not be used, whether it's TB positive, whether the patient is having a past history of TB or the patient is not having a past history of TB, doesn't matter. I'm going to use a terminology called Takayasu arteritis only. If it matches the presentation, then it will be Takayasu arteritis only. That's one. That is the reason why previously this Takayasu arteritis has been given by another name that is called as Manto positive vasculitis. It's also given by another name called as Manto positive vasculitis. That is because it has a very strong association with, your tuberculosis. That's why. So nevertheless, if you take the clinical features of Takayasu arteritis, the most common vessel that will be affected is the subclavian artery. So that will be the most common vessel that will be affected. Because it affects the subclavian artery, it will result in arm claudication because of reduced perfusion to the arms. And this is the most common symptom that the patient comes with. If somebody asks you the most common sign of Takayasu arteritis, usually it will be absent radial artery pulse only. Absent radial pulse, not ulnar pulse. Most common finding will be the absent radial pulse. And because of the same, they might be having asymmetric pulses, asymmetric blood pressure. One of the important cause of asymmetric blood pressure, BP difference between two arms by more than 20 milliliters of mercury. So definitely these are very important as well. And these patients have a substantial amount of hypertension. They can involve aortitis, aorta and its vessels. So because of aortitis, they can result in aortic aneurysm formation. They can result in dissection of aorta, possible, and they can result in strokes and transient ischemic attacks if the, aortic arch vessels are involved. Then they can result in substantial amount of hypertension. This is very classic of Takayasu compared to giant cell arteritis because they tend to involve the renal artery also. Because of renal artery involvement, sometimes they can result in substantial amount of hypertension due to RAS activation, and that's very classic. In both the cases I have seen, both had a severe hypertension. In fact, both of them had an uncontrolled hypertension. Stroke stay and even syncope. Syncope is also possible because of reduced perfusion to the brain. And these findings, aortitis findings, are not so classical in giant cell arteritis, but very, very common and classical in Takayasu arteritis compared to giant cell arteritis. So aneurysm, dissection, stroke, stay, syncope, severe hypertension because of renal artery involvement. All these are classic in Takayasu arteritis compared to the other giant cell arteritis. Anyway, in pathology, you would have studied three different phases of Takayasu arteritis. So initially, you will have a pre-vasculitic phase. then you have a vasculitic phase, then finally you have a burnt out phase. So that's how you have three different phases will be there. So that you would have studied in pathology. So in the pre-vasculitic phase, the patient will not have any symptoms or signs, but they'll be having only constitutional symptoms. So first pre-vasculitic phase, patient will have only constitutional symptoms, otherwise no problems. Then we have a vasculitic phase where there'll be, ongoing vessel inflammation and active vessel inflammation will be there. This is the time where you start getting the classical symptoms and signs of a Takaiso arteritis. And this finding, this time is also, they'll be having a significant elevation of the inflammatory markers, CRP, ESR, and all this stuff. And finally, they go for a burnt out phase where they'll have constitutional symptoms here also, where they will have reduced constitutional symptoms, but they will have a complete vessel stenosis of different areas of vessels. That is because of vessel fibrosis, because of continuous inflammation. So there are three phases: pre-vasculitic, vasculitic, and burnt out. Pre-vasculitic only constitutional symptoms. Vasculitic phase, they will be having typical symptom signs of Takaisu along with constitutional symptoms. In burnt out phase, the constitutional symptoms will go down and they'll go for a vessel stenosis. Because of that, they'll be having only ischemic symptoms, what you're talking about. As far as the investigations are concerned, here also the inflammatory markers will be elevated for sure, because it's a vasculitis. Patient will of course have constitutional symptoms, no doubt about that. And apart from that, the most important test that we need to do is a CT angiogram or probably an MR angiogram, or even invasive angiogram can be done. But in the current era, we prefer more of a non-invasive testing. So CT angiogram must be more than enough, as much as possible. So typically in CT angiogram, MR angiogram, you will see the typical vessel wall thickening with skip areas. So this is very classical of Takaiso arteritis. You will see in the subclavian artery very typically, most commonly, or you can use a FDG PET. Remember, this PET scan can be used in any large vessel vasculitis. This is to identify the aortitis in these patients. So that's what you're going to see in the FDG PET. So PET scan, aortitis, because the aorta will be red and taking up a lot of tracer because they are heavily inflamed. So that is to tell the aortitis. Whenever there is aortitis, you know it's a large vessel vasculitis. So remember, the differential diagnosis giant cell arteritis as well. But you know how to diagnose. There will be a lot of Himalayan differences will be there between giant cell arteritis and Takaiso arteritis, even if you have a aortitis. So that should not be confused. Elderly, headache, giant cell arteritis, younger patient coming with more of arm claudication. So more of a Takaiso arteritis. So FDG PET is also coming up as one of the important investigation. And for monitoring purpose, you can use angiogram again, CT and MRI angiography, but it's a very difficult disease to treat, very difficult to treat as well. So usually, like for giant cell arteritis, I'll be using steroids as a mainstay. On top of that, if I want to use steroid sparing agent, I can use methotrexate, but you don't have good evidence like that of giant cell arteritis. But nevertheless, I can use methotrexate, I can use azathioprine, I can use anti-TNF agents that are shown to be decently beneficial here. And then even tocilizumab has been tried in this particular cases. So like giant cell arteritis, tocilizumab. So it is just an extrapolation of what all the things that we have used in giant cell arteritis. It's just extrapolating here. But remember, evidence is very poor. Because this is an Asian disease, I think many people have been ignoring this disease for a long time. So, but still, evidence is very poor. We treat with steroids. In my practice, I usually give this steroids MTX in and out to these patients. So they do respond to an extent. And I didn't have any follow-up with that particular lady, that obese lady, for the last 8 months. Maybe because of COVID, nobody's coming to the hospital. Maybe because of that particular setting. But nevertheless, it's not a very easy disease to treat. It's a very difficult disease to treat. Invariably, the patients might die at some point of time. And many of these patients should receive aspirin also, because of the thrombotic risk is still there because of heavy ongoing inflammation. Thrombotic risk is always there. So you have to give thromboprophylaxis and protection for them in the form of aspirin or clopidogrel. If the vessel goes for burnt out phase, if they go for severe stenosis, then you can do grafting, and endovascular dilatation process also can be done, like that you do for coarctation of aorta. But nevertheless, that's old. That's very late stages. So Takaiso arteritis in exam, very easy to diagnose. Even real time, it's very easy to diagnose this kind of asymmetric pulses, BP, absent radial plus arm claudication, having a syncope, presentation with syncope, and a CT MRI showing vessel wall thickening and skip areas, and development of severe hypertension. That's all. So this is going to be the Takay's arteritis in exam. Treatment same like that of giant cell arteries. You're going to treat with steroids plus or minus a sparing agent like methotrexate. That's all. Nothing else. Then moving to the medium vessel vasculitis. As far as the medium vessel vasculitis is concerned, one of the important medium vessel vasculitis is going to be the Kawasaki disease. That's going to be really important. I think after Kawasaki, we'll get a break. So Kawasaki disease is a disease of children. We know that. Number one. Previously, it was the most common vasculitis in children, but currently it is the second most common vasculitis in children. Second most common. The most common vasculitis in children is right now enoxaparin purpura. The second most common vasculitis in children is Kawasaki disease. Anyway, I don't think they will be asking you this question in the first place. Usually, the peak incidence of this disease is going to be the 9 to 12 months. That is in the infantile period. 9 to 12 months of age. That's the infantile period. But typically happens within 5 years. Overall, it happens within 5 years of age. After 5 years, to get Kawasaki is extremely rare. Even though there are some atypical Kawasaki's that we do see in practice, but after 5 years, it's rare. Within 5 years, it's extremely common. So etiology-wise, we don't know what is the origin of Kawasaki. We believe that probably Staphylococcus aureus play a little bit of role, and even Streptococcus plays a little bit of role. In Staphylococcus, the toxin TSST1, toxic shock syndrome toxin, protein 1. So that could play a role. We don't know. In Streptococcus, you have the streptococcal pyrogenic exotoxin. So SP, streptococcal pyrogenic exotoxin. SP could play a role. Again, it's a question mark. That's what we believe right now as a probable cause of Takay's arteritis. Then as far as the clinical features is concerned, the fever is going to be the most important. The febrile nature of the patient is going to be more important. That's why I'm going to start with fever first. Fever means usually more than 40 degrees C, persisting for at least more than 1 week. By definition, it's more than 5 days at least. More than equal to 5 days. In your AOST diagnosis, it's 1 week. But here, as per the diagnostic criteria, it's 5 days or above. At least more than equal to 5 days. And no response to any sort of antibiotics. Because many times in pediatric practice, it's common to start with an empirical antibiotics, but there won't be any response to empirical antibiotics that you start with. So this is a characteristic feature, but there can be a transient response to antipyretics, but not to antibiotics. Then you have a kind of enanthem. So what do you mean by the enanthem? So whenever you see rash outside the body, it's an exanthem. Whenever you see rash inside the body, that's called as an enanthem. So enanthem means they will have oropharyngeal manifestations, typically in the form of oral ulcers may be there. And they can also have this kind of cracking and fissuring of the lips. Cracking and fissuring of the lips. The images I'll show you in some time. And apart from that, these patients may also have this kind of a tongue inflammation called as strawberry tongue. That is due to glossitis. Remember in exam, strawberry tongue goes towards Kawasaki disease and strawberry gingiva goes towards a vaginous granulomatosis. But even though I don't really think those sort of questions will be the key for your diagnosis in exams anymore, as they are moving towards a more clinically oriented approach. So strawberry tongue is a very important feature of Kawasaki once upon a time. And really these patients' tongue looks like strawberry. That's the take home point. So these are the oropharyngeal manifestations, enanthems that these patients can get. And third, they will get bulbar conjunctivitis, the bulbar conjunctiva. And one of the important points with regards to this bulbar conjunctivitis is the fact that it will be bilateral and mostly it's symmetric. It will be more pink than red, called as a pink conjunctivitis and not a red conjunctivitis. It's non-exudative in nature, which means what do you mean by non-exudative? Which means it is having no pus and it is sterile and it doesn't have any bacterium or virus in it. It's a sterile form of conjunctivitis without a pus, non-exudative form of conjunctivitis. Then you tend to develop a characteristic Kawasaki rash. And very commonly in the trunk, most common location of Kawasaki rash is the trunk and very pronounced in the groin area. Groin area and the perineal area is the place where it will be extremely pronounced. It can be vesiculous or bullous, or you can, it cannot be vesiculous or bullous. It will be more of a macular kind of rash, which I'll show in some time, but very classical in the groin area and the perineal area. So many times why this is important is because this might be confused by the mother as a diaper rash, which is diaper is very commonly used in infants. So they can confuse this for a diaper rash. That's why groin area and perineal area is something which you have to look for. If you want to look for a Kawasaki rash, it can never be vesiculous or bullous or vesiculobullous. It will not show any kind of exudation outside. And next, the most important point in Kawasaki is the internal organ involvement. That is very classical in Kawasaki. As far as the internal organ involvement is concerned, the most deadliest thing that Kawasaki causes that we are actually worrying about is the coronary artery involvement. They can produce coronary vasculitis and subsequent aneurysm formation. And because of that, they can result in development of myocardial infarction and heart failure. A 9-month-old child, 8-month-old child developing MI and sudden death because of MI. Imagine, that's very bad. So that's why this is a very important disease. It can have other organ involvement also, but coronary involvement is classic of Kawasaki. And this aneurysm can be macroaneurysm. It's not micro. It can be macroaneurysms. And MI and heart failure. These are the most common cause of death. Most common cause of death is cardiovascular disease in Kawasaki disease. The most common cause of death in Kawasaki disease patients. And apart from that, they can get this characteristic lymphadenopathy. Typically, the lymphadenopathy will be in the cervical region, very characteristically, typically in the anterior-cervical nodes. That's going to be extremely common. And most of the time, it will be unilateral, a single node. Unilateral, single node in anterior-cervical region, very, very classical. I mean, in the setting of what all other clinical findings you see, that's classical of a Kawasaki disease. And they can develop something called extremity changes. Extremity changes. So what are the extremity changes that you can see? You can see erythema and edema of the hands and feet. Edema of hands and feet. Extremity means we're talking about hands and feet. Erythema and edema of the hands and feet. Then associated desquamation may be seen in the hands and feet. And usually edema happens before desquamation. Desquamation is a late finding. Edema usually tends to happen before the desquamation. So now you can understand that why I told you febrile, because that's basically a mnemonic for understanding the criteria for Kawasaki. So fever, F, enanthem, bulbar conjunctivitis, rash. Then we have internal organ involvement, lymphadenopathy, and extremity changes. You have this mnemonic febrile. So that's the mnemonic for understanding Kawasaki disease. This is also the criteria for diagnosing Kawasaki, WHO criteria. But not only this, you have multiple other features of Kawasaki, apart from the ones which I've told you. Like for example, you can have a sterile pyuria. Sterile pyuria. And second thing, I mean, this can be a problem in the setting of Kawasaki disease. And more importantly, you might be diagnosing this as a urinary tract infection, and you'll be treating more and more antibiotics because you're seeing pulses in the urine. And at the same time, this WBCs that you see in the urine is not basically neutrophils. So if you typically take the leukocyte estrase, that will be negative. So if you really want to know whether it's infectious or not, you can do a test called leukocyte estrase. Because the WBCs that are coming are not predominantly leukocyte, neutrophils, the leukocyte estrase test will be usually negative. And these pus cells are basically, these WBCs that are coming in the urine are not coming from the, like your bladder or from the upper urinary tract. These pus cells that are coming are basically coming from the urethra. So if you still have a doubt, you can put a Foley sample and then you take the urine and see the pus cells will not be there. So if you really want to know, that's only traditional, but all other clinical findings will tell you it's Kawasaki. But if you think it's a UTI, but if you want to confuse with, you are confused, and if you want to differentiate Kawasaki, take the sample from the Foley's catheter, and because it's coming from the urethra, Foley's catheter will not show any pus cells. At the same time, most of them are not neutrophils, so that leukocyte estrase will be negative. So these are things that goes against the diagnosis of urinary tract infection in this particular scenario. And they can develop arthritis, a form of arthritis and arthralgia. It can be small joint and can be having the typical MCP, PIP location also, like this thing. And the third thing that's very important, and it's been a revelation in Kawasaki, is the reactivation of BCG scar. It's been shown to happen in many studies that the original BCG scar that the child has received will get reactivated now. So that's a reactivation of BCG scar that can happen. Clear? That's all. And the acute phase reactance will be elevated. It will be increased. So there are three phases of Kawasaki basically. One is called as a like acute phase, then it's called a subacute phase, and third one is called as a convalescent phase. So we'll see the findings in this acute phase. Then we have a subacute phase. Then we have a convalescent phase. So as per the definition, acute phase lasts for the first 1 to 2 weeks. Within 2 weeks, convalescent phase lasts for the second week to fourth week. So that's 2 to 4 weeks is subacute phase, and beyond 4 weeks, by definition, we call it as a convalescent phase. Remember, the definition of convalescent phase, even though we call it as more than 4 weeks, when you normalize the ESR and CRP, so when the ESR and CRP normalizes, that is actually the definition of the convalescent phase, which means the inflammation is gone. So that is the time where you call it as a convalescent phase. Usually it takes more than 4 weeks for that. So if you take the, clinical signs. So usually clinical signs will appear during the acute phase, and the clinical signs will start disappearing slowly during the subacute phase. And once the ESR and CRP becomes normal in the convalescent phase, becomes normal, that is the time where we call it as a convalescent phase in the first place. So, but nevertheless, apart from the timing, let us see what will be the classic distribution of the symptoms in Kawasaki. Kawasaki is a very common disease even now in tertiary care centers. Especially my hospital is a pediatric care center, so we do see some Kawasaki disease patients very commonly. And fever is very characteristic of an acute phase of the illness. It will not be seen in subacute or convalescent phase. Then at the same time, you have that characteristic lip and tongue changes. That fissuring of the lip and cracking of the tongue and the lip and strawberry tongue, very classical of an acute phase, not seen in the subacute or the convalescent phase. Then as far as the lymphadenopathy is concerned, once again, it can be seen in acute phase as well as subacute phase, but it's not a feature of a convalescent phase. Then if you take the arthritis, for example, arthritis is not a feature of an acute phase or a subacute phase. It's very classical of during the convalescent phase. That is the time where you develop arthritis. Just hold on. Sorry for the interruption. So arthritis, which is going to be happening in the setting of a convalescent phase only. And if you take the ESR and CRP, as I told you, it will be elevated in both acute and subacute phase. The normalization of ESR and CRP will mark the beginning of the convalescent phase. Then if you take the skin problems, the extremity changes, usually the rash in the groin and the perineal area is characteristic of acute phase, but the extremity changes, the desquamation, rash and edema also. Edema can be seen in acute phase, whereas this desquamation will be seen in the subacute phase, and you will not get any skin changes in the convalescent phase. But some studies tell that nail changes can happen in convalescent phase, but generally skin changes is not a feature of a convalescent phase. And as far as the cardiac manifestation is concerned, typically you will result in development of myocarditis here, and you can result in dilatation of coronary vessels. Dilatation of coronary vessels can be there during this phase, but the classic aneurysm formation happens during the subacute phase only, and there is nothing in the convalescent phase. Yes, ESR CRP can normalize, but still arthritis can happen. Arthritis classically happens in the convalescent phase only. Fine, during the recovery. But nevertheless, most important point here is to note that this dilatation is not equal to aneurysm. That's very important. So coronary artery dilatation can happen in the acute phase itself. That is because of inflammation. But if you treat on time, you can actually prevent the development of aneurysms. That's very important point. So dilatation is not equal to aneurysm. So a Kawasaki disease child who get coronary artery dilatation may not necessarily progress to aneurysm. You can prevent the development of aneurysm by giving treatment much early, appropriate treatment. So these are difference between acute, subacute, and convalescent phases. So which means that marks the importance of treating the patient in the acute phase itself. If you miss the bus, if you don't treat there, then the patient will develop aneurysms, and there is a lot of chance of developing death in these children. As far as the investigations are concerned, there is no real investigation needed. ESR CRP may be elevated like all other vasculitis because of inflammatory reaction in the body. Plus, apart from that, the gold standard, if they ask you, of course, it's going to be the coronary angiogram. But coronary angiogram is not routinely done, because for diagnosing Kawasaki arteritis, you don't need coronary angiogram. But one investigation which used very commonly is echocardiogram. Echocardiogram is the one that is typically used for monitoring the Kawasaki disease. Coronary angiogram is the gold standard, but not routinely done unless until it's extremely specified for. Apart from that, echo itself is more than enough for monitoring purposes. Absolutely more than enough. They'll ask you some risk factors for development of aneurysms. What are the risk factors for development of aneurysm? Not dilatation, aneurysm formation. So number one, extremes of age. For example, you get sort of Kawasaki within 1 year of age or more than 11 years of age. Atypical Kawasaki's have a higher risk of development of aneurysms. And Asian geographic distribution itself is having, Asian descent itself is having some risk of development of aneurysm. And if there is a fever beyond 2 weeks, fever is persisting beyond 2 weeks, risk factor for development of aneurysm. And delay in treatment. Delayed treatment initiation. Actually, the most important treatment is IVIG. So delayed treatment initiation is a risk factor of development of aneurysm. And there has been some markers that's been, and male gender. Male children have a high risk of development of aneurysms, in fact, even giant aneurysms. And there are some laboratory markers that have been shown to have a correlation with aneurysm. One is the WBC count, if it is more than 12,000, as a risk of developing aneurysms. And the hematocrit is less than 35%, has been shown to have a risk factor for development of aneurysms. And presence of hyponatremia indicates a severe disease. And these are laboratory markers that can tell the risk of development of aneurysms. Please understand, coronary dilatation alone, if in echo you see only dilatation, does not have a risk of MI, is not equal to risk of developing a myocardial infarction. Once you develop an aneurysm, then you have a risk of developing myocardial infarction. So that is why we need to prevent the development of aneurysms by treating in the coronary dilatation phase itself. So if they ask you maximum risk of development of MI, so I told you risk is there, but when will the maximum risk, what is the time period where the maximum risk will be there? So by around 6 to 12 months post Kawasaki disease, post 12 to 6 to 12 months, that is the time period where there is a highest risk of development of myocardial infarction. In the 6 to 12 months post Kawasaki disease, after resolution, 6 to 12 months is the time where the highest risk of developing myocardial infarction is there, and it's existing. And remember, the risk will continue till adulthood. For example, even an adult patient, if I see a coronary aneurysm, I will think about a childhood Kawasaki only. It's such a common cause of aneurysm in the world. Right now, if you see any patient with a coronary aneurysm, even in an incidental coronary angiogram, you always ask history of childhood Kawasaki. So that will be usually due to Kawasaki only. So which means the risk of MI is not only during the childhood, not only even though it's maximum in the first 6 to 12 months, and the 6 to 12 months period, it's going to still extend into the adulthood also. Any coronary aneurysm and angiogram, even if you find incidentally, always think about a childhood Kawasaki. It's such a common cause of coronary aneurysm, but even though it's a rare disease. Apart from that, if you start treatment early, for example, the treatment is IVIG, we know that. That's the treatment. If you initiate IVIG with treatment, only 1 in 4 will develop coronary aneurysms. If you don't treat these patients without treatment, sorry, 1 in 25 will only 1 in 25 will develop aneurysms. If you don't give any treatment, 1 in 4 will develop aneurysm, which means IVIG reduces the incidence of aneurysm by 6 times. At the same time, the incidence of, even if 1 in 25 get aneurysm with IVIG, there will be only small aneurysms. There won't be any giant aneurysms. So the size of aneurysms will be less after treatment with IVIG. And at the same time, the overall incidence of aneurysm is also going down with the help of treatment. So that's why initiating treatment, that's why I'm telling multiple times, this disease is something you should not miss, and early treatment saves the child. Stitch in time saves 9. Early treatment is definitely going to save the child from development of bigger aneurysms. So if we talk about the treatment, so treatment wise, the most important treatment is going to be IVIG plus aspirin. That's what we use basically. Aspirin is to prevent the cardiac events. And of course, the IVIG is the gold standard treatment for Kawasaki. You know how IVIG works, we don't know. Based on the hypothesis we established in the beginning, this is due to the toxins. That's what we thought. So the staphylococcal and streptococcal toxins. So that's the probable reason. So majority of the community acquired immunoglobulins will contain antibodies against these toxins. So probably that is one probable reason why IVIG works in these patients. But apart from that, we really don't know. Suppose if there is a poor response to IVIG or first dose of IVIG, the dose of IVIG is 2 gram per kilogram. You can repeat IVIG in this setting. Still, if you have a poor response, then you can go for a pulse methylprednisolone. In children, it will be a different dose, 35 milligram per kilogram. That's a pulse methylprednisolone. In children, you have to give by kilogram basis. Still, if you have a poor response, then there's an indication to start with anti-TNF alpha drugs. But anyway, in exam, they don't go to this deep and all. They'll be usually asking what is the treatment for Kawasaki disease. Answer is absolutely going to be IVIG only. So intravenous immunoglobulin. So as per the echo findings, because you're going to use echo for monitoring, even with treatment or without treatment, some children may develop aneurysms. So based on that, I can tell small aneurysms, which is typically defined as less than 5 millimeter in size, or I can tell medium-sized aneurysms, which typically defined as somewhere around 5 to 7 millimeter in size, or we can call it as a giant aneurysm, which is typically more than 7 millimeter in size. So as far as the small aneurysms are concerned, small aneurysms is concerned, you're going to treat with aspirin only for a short-term period. I'm not going to treat with a lifelong aspirin. Aspirin is needed only for a short-term period. As far as medium aneurysms are, no. Aneurysm means, I'll be treating with aspirin for a long-term period, which means essentially for long-term period. If it's a giant aneurysm, I have to treat with aspirin along with warfarin, because here the risk of MI is substantially high. So I'll be treating with aspirin and warfarin for a long-term period. Long-term means essentially lifelong, but in books you don't give lifelong, you'll give long-term period. But if it's only dilatation, aspirin alone for short-term period is enough. Short-term in the sense like only till that convalescent phase. Only till we start with aspirin here, isn't it? If it's only dilatation, then I'll be giving only till the convalescent phase. Once the convalescent phase comes, I'll not give aspirin. I'll stop giving aspirin. But if there is an aneurysm formation, the follow-up echo, then depending on the size, if it's small or medium, then I'll be giving long-term aspirin alone. If it's going to be a giant aneurysm, I'll be using aspirin and warfarin for a long term. So I think that marks the end of the Kawasaki disease also. Let us see some images. And this is an image which I have not shown. Very characteristic of a giant cell arteritis, where you are seeing this is a normal superficial temporal artery, where you are seeing the tunica media, and this is a tunica intima. In the intima, you are seeing something called the interelastic lamina, which is very nice and tight here. Interelastic lamina. And when you take the giant cell arteritis, in giant cell arteritis, the most important feature is the formation of this kind of, let me put this, in giant cell arteritis, you see this formation of giant cells here in the vascular wall. So, this is a typical horseshoe shape. So this is a Langhans shaped or foreign body giant cell. You should be able to tell what is the type of giant cell that you're seeing, because it's horseshoe shaped arrangement of the nucleus. What is the type of giant cell? Yes, of course, that's a Langhans type of giant cell that you see there. And more importantly, if you look closely, you don't really see the interelastic lamina that clearly. You can see there is an interelastic lamina that is there, but this area, I don't know it is there or not. It's disrupted. Again, I'm seeing some interelastic lamina here. If you see closely here, it's there, and it's not very clear. So it's disrupted. So the disruption of the interelastic lamina is one of the characteristic findings of vasculitis. In superficial temporal artery, you can see this. And of course, if you really want to know, is there any disruption of the interelastic lamina, you can use a stain called Verhoff stain. Verhoff stain is an elastin stain that stains the elastic fibers. So here the interelastic lamina can be well stained by Verhoff stain. If you use that, you can see interelastic lamina very nicely here. But there are a lot of areas that interelastic lamina is not visible and it is disrupted. So that's classical of giant cell arteries. If this finding is seen in superficial temporal artery, along with the giant cells that you see, along with the inflammation in the vessel wall that you see, of course, it's very characteristic of the giant cell arteritis. You know that. So they might be asking you about the importance of the Verhofstadt. I think we have seen this, and you can see this is a example. I think this is one of my cases only. So where you can see the Takayasaitis very clearly, there is a substantial dilatation of the aorta. The wall thickness is increased. Then you can see this is also an evidence of increased wall thickness over here. And you can see there is a stenosis of the vessels. There's a burnt out face. And at the same time, there's a PET scan which shows, like angry red aorta. The aorta ascending, descending, all the branches are taking up the tracer very badly. That is a sign of a severe inflammation of the aorta, aortitis. And this is an example of a Kawasaki disease. This is the best example of edema of hands and feet that you see. And you can see the erythema, edema of the hands and feet, puffy hands, and characteristic diaper rash. I mean, not diaper rash, this groin rash and perianal rash, which I told you, very characteristic of Kawasaki. This is an example of an arthritis. MCP and PIP is involved here. And you see the characteristic desquamation of the skin in many areas. And this is the reactivation of the BCG scar, this kind of an image. I think it's not, it's easy only. So reactivation of the BCG scar, and you can see a sort of a pink conjunctivitis here, which is typical of more pink than red. That's all. Clear? And if people did not see this properly, I can, let me remove my image typically. So now I think you'll be able to see this properly. So this is the, like disruption of the interelastic lamina we're talking about. So, and the stain I told you is the Verhoff stain. And this is the PET CT uptake of aorta, showing aortitis, stenosis of the aorta. And this is the different findings which I showed you. The pink conjunctivitis, reactivation of BCG scar, desquamation, arthritis, perianal rash, groin rash, erythema, and edema of the hands and feet. I think that must solve it. I think we can go for a break now. You can come back at 4:15. So hopefully we'll start at 4:15 and I'll complete the vasculitis in maybe a 1 hour time. After that, we'll move on to nephrology section for today. Bye-bye.